Good afternoon, everybody. Welcome to this presentation known as the Tri-State Conference put on by GALA. My name is Vinod Rustgi, and I'll be helping out with the program. Sorry about the monsoon-like weather. I've been told that it'll be much nicer tomorrow. We're gonna just go through some housekeeping. The GALA, or GI and Liver Association of the Americas, has had conferences going on since 2013. They were initially in Austin, Texas, but as you can see annually, they've spread out over other parts of the country. I think this is the first one in New Jersey. This one is today and tomorrow, as you know, in Hamburg, New Jersey. And later this month, there'll be one in the Westin Galleria in Dallas. Our joint sponsors include the Texas Liver Institute, as well as the GI and Liver Association of the Americas. We wanted to thank the following companies for this supporting this conference: Shionogi, the diamond sponsor; AbbVie and Intercept as platinum sponsors; and then AbbVie, Ecosense, Gilead, Novartis, Prometheus, Salix, and Takeda. We'd like to extend a special thanks to AbbVie and Intercept for the welcome reception this evening, which will be in this tent starting at 5:30. There are also non-accredited industry-supported seminars and product theaters tomorrow between 12 and 1. So Bob Brown will be presenting, and please make a point of attending those as well. Tomorrow morning, there will be parallel sessions. The selected sessions are on the back of your name badge. You can see that they will cover GI woes from head to toe, IBD, viral hepatitis, and alcoholic and non-alcoholic fatty liver disease. As far as CME, you're eligible to receive up to 11 CME credits and ABIM mock points. You must complete the program and certificate activity. If you haven't done your pre-test questionnaire, please do that as well. The activity will be available starting Saturday afternoon on livegala.org and will also be emailed to you following the conference. You must participate in the same activity with an additional post-meeting questionnaire required by the ABIM. At that time, you'll be asked to provide your ABIM number and date of birth. Thank you again to the following companies: AbbVie, Allergan, Dova, Gilead, Intercept, Mallinckrodt, Salix, and Takeda for the educational grant to support this activity. Upon completion of this conference, participants should be able to understand chronic liver disease and GI disorders and describe evolving patient management and treatment strategies. To be able to integrate significant advances in therapeutic and diagnostic modalities into clinical practice, and to apply the latest clinical research, including future therapies, and their role in the context of the current clinical paradigm. Disclosures will be mentioned on each of the speakers and are available. So on the just as a reminder, please fill out your pre-test evaluation that was emailed to you if you have not completed it already, or you can go to livegala.org and do so now. The post-test evaluation and certificate certificate activity will be emailed to you as well at the same website. Slides and recordings from this conference will also be available there. So I have the pleasure of giving the first talk in this activity. My name is Vinod Rustgi. I'm at Rutgers, Robert Wood Johnson. And the topic is hepatitis C, which is, obviously even more in prominence since the Nobel Prize in Medicine this year was awarded to Drs. Harvey Alter, Houghton, and Charlie Rice. I think that it's been a remarkable story for all of all of us who've participated in the evolution from non-A, non-B hepatitis to what we have currently, which is the ability to treat and cure over 99% of our patients. I think that many of us have watched this or participated in clinical trials. I think there are names that deserve mention above and beyond the Nobel laureates who there are obviously only a finite number that can get that award, but Tom Merrigan at Stanford created a whole host of antivirals and is now emeritus. And also Bob Purcell, who had the Laboratory of Infectious Diseases at the NIH, as well as Steve Feinstone. Bob Purcell actually discovered the hepatitis A, D, and E viruses. He created the first animal model for hepatitis B, and also helped identify that there was a non-A, non-B agent along with Harvey Alter. So with that historical note, we'll go to my disclosures here. I'm going to cover the changing epidemiology of hepatitis C, the current treatment guidelines, and discuss recent changes in the black box warnings. You could probably substitute, regardless of your politics, WHO vision for Trump vision and viral hepatitis for COVID and get the same time frame. So the WHO vision for eliminating viral hepatitis as a major health threat by 2030 involves a 90% reduction in new chronic hepatitis C infections, a treatment of 80% of eligible patients, resulting in hopefully a 65% reduction in mortality rates. However, most countries are not on target for this. You can see in the left hand, the light blue bars are the countries that perhaps will meet those goals, and they include Australia, the UK. The ones in orange may be a little bit delayed by a decade, but you can see that 2/3 of high-income countries are actually not on target, and that includes the United States, which may not meet this target until 2050 or longer. So certainly people who are entering the field now will continue to see hepatitis C cases. One of the problems for us is the linkage to care, screening, but also linkage to care. We need to involve non-HCV specialists, primary care physicians, to help close some of these gaps. On your left, the proportion of tests by blue is the non-specialist, and on top is, the orange is the HCV specialist, red being the missing specialty. You can see that almost 1/3 of screening is done by non-specialists, but when it comes to treatment, that number is not even half. So you can see that we're trying to improve those numbers. Many states' primary care physicians are prescribing, officially, unofficially, but it's clearly a gap. The effectiveness of screening is displayed here. To meet that 2030 diagnosis targets, the United States must at least diagnose 110,000 cases per year until 2020. These are some old numbers, down to in the next 5 years, 89,000 cases per year, and at least 70,000 cases per year in the latter half of this decade. At current screening rates, 92% of US states are not on target. I can see that in blue, one of the states that is supposed to be achieving WHO screening targets is New Jersey. And I'm actually very surprised. I would welcome comments from the audience, but I don't see that happening in New Jersey. We also know that HCV is becoming bimodal. 15 years ago, we were worried about the baby boomers. We still worry about them. But much of the acute hepatitis and the new cases are in people who inject drugs, who are heavily, by demographics, are in their 20s and 30s. There is an increasing percentage of women. So in 2012, you can see the shift was veering to the left already, but now it's bimodal, where there's much larger numbers of females white, rural areas, a changing demographic. And that is related, as you know, to the opioid epidemic. So women, unfortunately, are caught up with men as far as injection drug use, and any opioid injection is associated with hepatitis C acute rates increasing. The HCV screening recommendations have evolved. At this point in time, we've basically gone beyond just screening the baby boomer cohort. So while we were all used to screening everybody between 1945 and 1965, at this point in time, the USPSTF has recommended screening of all adults between the ages of 18 and 79 at least once. So the current screening recommendations are one-time routine HCV testing is recommended for all individuals who are over the age of 18. These are the AASLD IDSA Infectious Disease Society screening recommendations. One-time HCV testing of all individuals with risk behaviors when they are less than 18 in age. And the periodic testing should be offered to all people who have behaviors, exposures, or conditions associated with an increased risk of HCV exposure. Annual HCV testing is also recommended for those who inject drugs and HIV-infected men who have unprotected sex with men. The treatment guidelines have also evolved. At this point, there's not much difference between these various organizations, but the AASLD, which is what we mainly follow here, has the recommendation that all patients with chronic HCV infection should be treated, except perhaps those who have a life expectancy of less than a year that cannot be remediated. Mostly those are patients with end-stage malignancies. The WHO is in concordance mainly, as is the European Association, with that recommendation. 99.9% of our infected patients can now be cured through the pangenotypic regimens available to us. One of those regimens, is of course sofosbuvir and velpatasvir for 12 weeks, which has a very high rate of SVR across all genotypes. Even the tough genotypes like genotype 3 has very good regimens and an SVR rate of 95%. Particularly important in a state like New Jersey where there's so much immigration and we see far more genotype 3 than we might in certain other parts of the country. Glecaprevir and pibrentasvir for 8 weeks with and without cirrhosis is another option available to you with similarly good SVR rates. At this point, the regimen is glecaprevir and pibrentasvir, Mavorette, is available for 8 weeks in treatment-naive patients with compensated cirrhosis. So very short regimens, very good results. As far as the EASL, European Association for the Study of Liver Disease guideline recommendations, EASL recommendations for treatment-naive patients without cirrhosis are 8 weeks of GP and 12 weeks of soft fel. The recommendations for treatment-naive patients with cirrhosis are 12 weeks across the board with either regimen. And then, of course, the only thing that needs to be done anymore in terms of pre-treatment assessment, really as a minimum, are proof of HCV replication and whether a patient does or does not have cirrhosis. The simplified treatments involve simply that, finding out if a patient has cirrhosis or not. And those who are perhaps not eligible for the simplified treatment include those who are treatment experienced, those who are cirrhotic, those who are liver transplant patients, those who are simultaneously co-infected with hepatitis B and HIV, those with end-stage renal disease, and perhaps and pregnant patients or contemplating pregnancy. By excluding advanced fibrosis and reviewing the drug-drug interactions and providing HIV and surface antigen testing, really those patients can have the simplified regimen of simply going on one of the two regimens, GP or soft-bell, with minimal monitoring and looking for SVR. HCV infection rates have been increasing among women of reproductive age in the United States. Between 2006 and 2014, by a surveillance system, 171,000 reproductive age women had with HCV were found, and 1,859 children between ages 2 and 13. Now, those number of reproductive age women with HCV exposure have doubled subsequently, or in that time interval, from 15,550 a year to 31,000 8 years later. The rate of HCV among pregnant women per 1,000 live births by state is shown here. It's increased 89% in that 8-year interval, with a substantial variation. As you know, the opioid epidemic plays a large part of this, and therefore the black areas which have the highest rate is in Appalachia. The intermediate rates are in blue, and those areas with low rates of HCV among pregnant women are in white. HCV screening is recommended during pregnancy is recommended by the AASLD and the IDSA. As part of prenatal care, all pregnant women should be tested for HCV infection, ideally at the initial visit. Whereas the CDC and the American College of Obstetricians and Gynecologists recommend selective screening with high risk behaviors, such as a history of IV drug use or long-term hemodialysis. So antiviral therapy, what role does it have in prevention of transmission? We know that the recommendation regarding HCV treatment in pregnancy is for women of reproductive age with known HCV infection. Antiviral therapy is recommended before considering pregnancy, whenever it's practical or feasible, to reduce the risk of mother-to-child transmission, which is about 5% if the mother is mono-infected. What's not recommended regarding HCV treatment in pregnancy is treatment during pregnancy due to the lack of safety data. The risk of vertical transmission in these meta-analyses has shown that if the mother is HIV negative, mother-to-child transmission is about under 6%. And it's almost double that number if the mother is both hepatitis C and HIV positive. As far as recommendations for HCV testing of perinatally exposed children and their siblings, all children should be of HCV infected women should be tested for HCV. Remember that the IgG crosses placenta, so the testing is recommended using an antibody-based test after 18 months of age in the child, and then testing for presence of viremia. The optimal timing of it is not known, but repetitive testing is not recommended for viremia. Those children who are hepatitis C antibody positive after 18 months of age should be tested after age 3 for viremia. And those siblings of children who turn out to be positive should also be tested if they were born of the same mother. Kentucky, it's an important issue. Almost 2% of births in Kentucky were to mothers with hepatitis C, and actually quadrupled in this 6-year interval. Unfortunately, and I think this is a recurring theme in hepatitis C, is screening may occur, but there's a real big drop-off between screening, confirmatory tests, linkage to care, treatment, and achievement of SVR. In Kentucky, in moms who were screened for hepatitis C, 1,890 pregnant women or mothers had lab results reported, of whom 1,500 had positive screening tests, but only 300, about 20%, had positive confirmatory tests. That means that 80% of women who were initially reported to have lab tests actually never had confirmatory test results available. Of the 695 children born to mothers with hepatitis C, 625 had no confirmatory test results. And so that means that of the cohort, 78% had no screening or confirmation. There are pangenotypic therapies that are now available for children. So GP is available. It's actually approved for treatment over the age of 12. The pediatric formulation is weight-based. As far as adverse events, it's very similar to what we see in adults because it's mainly headache and fatigue, and the efficacy is excellent. It is weight-based. Other pangenotypic therapy includes soft-bel. This is approved over the age of 6 or 17 kilograms in weight. You can see the SVR rates there. Hopefully, as further data becomes available, this regimen will be approved over the age of 3. As far as the sofosbuvir-based regimens in pediatric hepatitis patients, these are the ones that have been through trials. I've already mentioned the fact that we're hopefully going to have the ability to treat kids down to the age of 3, which would make sense to test them for viremia starting at that point. So we've got simple regimens, but there are certain things you still have to consider before initiating therapy. The safety profiles are here. So integrated safety analyses of GP show that serious adverse events are low and discontinuation due to adverse events are less than 1% or even non-existent. And similar data exists for soft-bel from the Astral and Polaris 2 studies. And again, the side effects that do occur are mainly headache and fatigue. Moving to patients with renal impairment, these regimens are also available pretty much without dose adjustment. So patients with CKD 1, 2, or 3, you don't really have to consider anything differently than patients who don't have CKD. Those with CKD stage 4 or 5, you can see that there's 3 regimens available. I don't think many of us use elbasvir or grazaprevir at this point in time, but GP as well as soft-bel are available and pangenotypic, and depending on the situation, maybe 8, 12, or 16 weeks of therapy. There are situations where there may be use of a protease inhibitor regimen that you want to avoid. So those patients who have Child-Pugh B or C may unfortunately have serious liver deterioration and even deaths have occurred. So protease inhibitor containing regimens, which include GP, which includes Zepotir, which includes Vosevi. There have been 63 cases reported, 3 of them in Vosevi, the bulk of them in Mavorep. Those baseline liver functions may have been part of the issue was that we sometimes miscalculate or the diagnosis of more advanced fibrosis may not be accurate. 50% of reported cases in this situation were patients who had no cirrhosis or compensated cirrhosis. And just as a reminder, it's a relative contraindication in Child's B and an absolute contraindication in Child's C. The Target International Consortium showed the safety and tolerability of DAAs in usual clinical practice. So this is a study of 4,829 patients, approximately half having cirrhosis and the various regimens. Now, these are not regimens with a protease inhibitor, they did see a 2% rate of hyperbilirubinemia over the level of 3, and drug-associated liver events, or DALE, were fewer than 1%, and they were mainly in cirrhotic patients. So certainly assess fibrosis, and that'll help you pick which regimen to use. Also, the reactivation phenomenon of hepatitis B is something to be aware of. Hepatitis B may become an active infection again in any patient who has current or previous infection and is treated with DAAs, and this is across the board, whichever regimen you consider. This is a review of spontaneous post-marketing cases. Baseline characteristics where the reactivation phenomenon was noted, and that was defined as a DNA increase or surface antigen seroconversion from negative to positive. This reactivation usually occurred 4 to 8 weeks after DAA initiation, with a mean of 53 days. And you know, we talked about the simple regimen. It's something in this situation where if you have a patient who has surface antigen or low-level viremia, or even just a core antibody, you might want to continue to do the 4-week blood test to make sure that there isn't an elevation in ALT, and follow their DNA level to make sure it's not increasing. In 62,000, almost 63,000 veterans with oral hepatitis C antivirals, where hepatitis B reactivation was defined as a greater than 3 log increase in HBV DNA, or if the patients were surface antigen positive but previously had been negative, you can see that only 9 out of 63,000 experienced reactivation. 8 of them had surface antigen positivity, but 1 of them actually was just a core antibody positive. So do that as part of your evaluation. You're checking HIV, you're checking the hepatitis B markers, and be aware that reactivation can occur. As far as drug-drug interactions, again, more of an issue with protease inhibitors. This is a study from a VA in upstate New York of over 4,000 patients, looking at the number of medications that a patient is on. You can understand that the older patients were more of a concern here, and those who are on who had multiple comorbidities. But at least there were 20% of patients in this veteran population that had contraindicated drug-drug interactions to 3 of the regimens, and 2% had actually contraindicated drug-drug interactions to all 4 DAAs. So again, level of fibrosis, hepatitis B markers and status, and drug-drug interactions are still a consideration in what is overall otherwise a very simple regimens. They're listed here for you. Blue is if a patient had no concerns about potential drug-drug interactions in these categories. Orange is to be careful about what you're doing, and red are absolute contraindications. So I think everybody is familiar with the warnings about amiodarone, et cetera. I think most of the time, the category of drugs that you run into trouble with are the anticonvulsants and trying to find substitutes for them. But you can run down the list here, and they're available, as you know, on apps put out by the University of Liverpool, HepI chart, and you can quickly look up what to avoid or what to be monitoring carefully. This is just more of that listing. So key takeaways from this are that improved screening and linkage to care are imperative. Changing demographics led to near universal screening. Treatment is safe, simple, highly effective. You can cure virtually everybody. But remember that DDIs, staging, and consideration of co-infection are still necessary. Be happy to go over any questions, and if there are. If not, we can certainly open them up again later. The next speaker is Dr. David Bernstein. He's at Northwell Hospital, eminent hepatologist. He'll be covering NAFLD and NASH, screening, current management, and treatments on the horizon. And I'm sure he'll address it extremely well.
Thank you all. Thank you, Dr. Rustgi. Thank you, the team from GALA. First and foremost, for those in the room, there is lunch in the back. If you want to grab it. For those at home, now's your time to go down to the kitchen or in the office, the cafeteria, grab a quick bite. And so with that, I think I'm going to get started. But Dr. Rustgi, I believe you took the clicker. Aha. There we go. Beautiful. All right. Makes it hard to go forward. So my role here is to talk about NASH and NAFLD. So just to start out with a summary, and then we'll sort of go into this. NAFLD is the most common liver disease in the United States. Currently the second most common reason for liver transplantation in the US, and the leading indication for transplant under age 50. It's also becoming one of the leading predisposing factors for the development of hepatocellular carcinoma, and cancer occurs even in people without cirrhosis. And interestingly enough, the majority of folks who have found to have NAFLD actually have normal liver enzymes. So we may need, and we'll talk about this, to have a high index of suspicion when evaluating these folks. So if we think about how many people in the United States have this condition, we don't know, but there are estimates. It's estimated that about a third of our population, or about 110 million people, have NAFLD. Of those, about a fifth, or 20 million, will have NASH. And overall, there are about 4 million people walking around with cirrhosis secondary to NASH, most of whom don't know that they have it. Which means this is a tremendous unmet need in our communities, which would help explain why we're seeing more and more of these folks presenting to transplant centers, but also makes it so important for us to try to intervene early, recognize early, and maybe as we get better, begin to implement processes that help prevent this disease progression. Because we are at a very early stage. You heard Dr. Rustgi talk about hepatitis C, and he ended by saying you can cure almost everybody. Here we don't have any approved therapies, so it's about recognition, and we'll talk about certain modifications that people can do. Of patients that are obese, and the greatest risk factors for having NAFLD and NASH are obesity and having diabetes. Of those patients who are obese, about 70% or greater will have NAFLD, and 30% will have NASH. Put that in the context that now roughly 30 to 32% of the US population is obese, and it's estimated by the year 2030 that 47% of the US population will be obese. The problems that we're going to encounter in the not too distant future are significant. So if you're a hepatologist or if you're interested in fatty liver, you really do have tremendous job security, because you're going to be inundated with these folks who come in. That leads us to, how do we screen for these patients that have fatty liver? If it's 1/3 the population, how do we actually go out and find them? Or should we go out and find them, which is probably the bigger recommendation or the bigger question? Well, if we look at 3 main societies, ASLD, the European Society, and the ADA, which is the American Diabetic Association, and we go through them sort of one by one. If we look at the ASLD, which is the US agent or US organization, which deals most with this from a liver standpoint, recommends no screening, but that we should have a high level of suspicion for NAFLD in patients with type 2 diabetes, but they specifically don't recommend any type of screening. The Europeans, little different. They recognize that obesity and the metabolic syndrome is a risk factor, and patients with obesity and the metabolic syndrome should be screened with liver enzymes, with or without an ultrasound. And those patients that are at high risk, over age 50, type 2 diabetes or cardiovascular disease, should be screened for more advanced disease, looking for degree of fibrosis. The ADA, non-GI, non-liver, but people who deal with diabetes all the time, recommend that NASH and fibrosis screening in all patients with type 2 diabetes or pre-diabetes with an elevated ALT. And we are really seeing the endocrinologists taking the lead right now in beginning to diagnose. I practice across the river in New York. Our endocrinologists are very, very engaged in looking for these patients. In fact, most of our endocrinologists have placed FibroScans into their offices to screen all of their diabetics. And so, and this is really in the past 2 years been a major change amongst the population who's looking. So how do you look for NAFLD and how do you diagnose NASH and develop and determine fibrosis? Well, certainly have invasive modality, that would be liver biopsy. It's the best way of determining the degree of fibrosis, but it's really an imperfect gold standard. Why? You're only sampling a small area, and we do know that in liver disease related to fat, the changes are not ubiquitous, meaning you may biopsy one area which doesn't represent the degree of fat or fibrosis as others. And in addition, liver biopsy is invasive, and most patients don't want it. And since we don't have therapies that are approved, you have to question about what is your rationale for doing a biopsy. At this point, it's mostly determined prognosis, which leaves us with multiple non-invasive modalities: serum tests, blood tests, or imaging. And there are lots of different serum biomarkers which are available. I've highlighted 3 in bold here on the left, the serum biomarkers, the FIB4, the NAFLD fibrosis score, and the APRI. I've not highlighted them because they're simple. You can calculate themselves, you can do the calculation yourself on a smartphone without sending them off, and they don't cost anything extra, where the others are actually quite expensive, and we'll talk about that. There are also imaging that can be done. Various types of transient elastography, from a FibroScan to shear wave, and then more and more people are beginning to use, when available, MRI techniques, which are probably the best of all of the various imaging. But of course, MRIs are expensive, access isn't as easy, and again, difficult to obtain in many areas. So what about the NAFLD fibrosis score, or the FIB4? These are, again, things that you can calculate. The FIB4 uses 4 parameters: age, AST, ALT, and platelet count. The NAFLD fibrosis score adds BMI, albumin, and a yes/no whether someone has impaired glucose tolerance or diabetes. You pop it into a formula, it gives you a number, and these are very good at determining if someone has significant degrees of fibrosis or minimal fibrosis. In the middle, not so good, but free, easy, and gives you a lot of quick information, and most of the EMRs can be programmed to calculate these automatically for you when you order. What is probably the best non-invasive test, and one you can't calculate on your own, is the Enhanced Liver Fibrosis Test, or ELF. It uses certain measures. It's commonly used in Europe. It's a send-out test, but not yet approved in the US. We were told in 2020 it would be approved, but obviously everything in 2020 has been pushed back due to COVID. So we'll see what happens the end of this year or in 2021. But that may be a test that's available to us. Now, people talk about NASH a lot, and people talk about NAFLD. We can diagnose NAFLD on imaging, either ultrasound or CAT scan. We can't diagnose NASH. NASH does require currently a biopsy to evaluate the degree of inflammation. So we can use imaging for fatty liver, but we can't diagnose NASH without a biopsy. Again, most of the clinical studies then that treat NASH require you to, have a biopsy done. We can, through transient elastography, measure degree of fibrosis and how much fat is present. Transient elastography, FibroScan, more readily available, easy to do, highly reproducible, inexpensive to the patient, but expensive to an office. And so you have to make a decision. Interesting, again, in our area, as I said earlier, these devices are being purchased more by endocrinologists than they are by gastroenterologists. The hepatologists all pretty much have it. And then there's MRE elastography, or MR-PDFF, protein density fat fraction. MRI enables us to get a look at the entire liver and get a determination of fibrosis and fat, probably much better than any of the transient elastography. But of course, MRI requires approval by insurance, much more difficult now in a Medicare population with the new regulations as regards to how to get imaging approved, but gives a lot of information to us. This is just an example of a patient that had significant fatty liver, was overweight, underwent bariatric surgery, and you can see from left to right in a period of 6 months, significant improvement in the degree of steatosis that the patient had. So a third of the liver before surgery was fat. 6 months afterwards, it's about 3%. Showing you that weight loss actually works. Doesn't matter that it was bariatric surgery, but if you lose weight, you can see significant improvements, and the improvements happen quickly, which is why sometimes it goes the opposite. When you're seeing patients, you repeat a FibroScan once a year, you see that there's more steatosis, and you ask them if they've gained weight, and they said, sure. And you can predict based upon what you see, on FibroScan. Again, to diagnose NASH, you need to have a liver biopsy with classic findings, but with 1/3 of the US population having fatty liver, we're not going to be biopsying 1/3 of the population. So you have to be very selective in who you decide to actually biopsy. These are some guidelines that were put together by the Chronic Liver Disease Foundation. A group of hepatologists and gastroenterologists came together and said, what would we recommend to doctors when a patient is referred for suspected NAFLD or NASH? Simple, start out by getting a good history. Make sure there's no alcohol history, because many people do drink. Many times if they do drink, it's a combination of ASH and NASH, alcoholic steatohepatitis. Rule out other causes, and then obtain some sort of imaging. You can't really see this well, and I'm not going to go over it one by one, but just note, and then you have someone that you suspect is having NASH or NAFLD. You're going to look at the serum biomarkers. You're going to get an imaging, and you probably do, both of those. If for some reason there's a discrepancy between the two, then biopsy would be warranted. And so you have lots of different modalities now to assess these patients. So now you've made the diagnosis, and now we have to say, what do we do, right? Because this really does become, for these patients, the battle of the bulge. This is going to be all about weight loss. And so when we have diagnosed with someone with NASH, what are our goals of therapy, right? And the goals are pretty broad here. We'd like to improve any metabolic abnormalities. Certainly, if there's inflammation, we want that decreased. If there's fibrosis, we'd like to stop it in its tracks or ultimately reverse it. And we'd like to prevent the development in the future of it, more advanced liver disease, cirrhosis, liver cancer, etc. And ideally, systemic outcomes as well, improve or decrease the risk of stroke, heart disease, other things associated with diabetes. So they're pretty broad goals when we talk about, NASH itself. The first line of therapy is going to be lifestyle modification, not drug therapy. So that involves caloric intake reduction, significant caloric intake reduction, and having a discussion with patients for a prolonged period of time about what they've eaten. Now, that's somewhat problematic because we all don't have a lot of time in the current 2020 world of seeing patients, of spending a lot of time going over, diet. But ideally, you want to decrease patients' caloric intake by about 1/3 and certainly limit their use of anything with fructose, since fructose is going to be your biggest enemy when patients are being treated for fatty liver. You'd hope with that caloric intake comes, decrease in caloric intake comes weight loss. As little as 3 to 5% loss of body weight will show significant reduction in steatosis, but more than 10% will begin to see significant improvements in fibrosis. So weight loss actually works. We've talked about diet, now we got to talk about exercise. So you have all these patients coming in, first you tell them that they're overweight, they have to lose weight, now you tell them they have to exercise. And they really should exercise about 30 minutes a day, every day, in some sort of aerobic exercise. And then you have to have the discussion regarding alcohol. And you really want to minimize their alcohol intake and have that discussion. The nice thing is you can tell them coffee has also been shown to be effective in preventing disease progression. So you can tell them as long as their heart can handle it, to have as much coffee as they would like, whether it be caffeinated or decaffeinated. And this is from a study that was published now 3 years ago. And I just think it's incredibly important. If you look on the right-hand side of this slide, and you can see that in patients who lost more than 10% of their body weight, so that means if you start out at 250 pounds and you lose 25 pounds, which doesn't seem like a lot for someone that size, 90% had NASH resolution, 80% had fibrosis regression, all had some improvement of steatosis, but only 10% of folks who went through these processes could actually achieve a 10% weight loss, which means we probably, as we initiate therapy, have to have multiple providers being involved in the care, including dietitians and other social workers, to help people stay on that diet and exercise program. So what diet do you recommend? There really isn't a lot of evidence for what to recommend, but certainly patients are going to ask this a lot, and it's a very reasonable question. So do we go sort of common sense wise? First question, should dietary sugars be limited in patients that have fatty liver? Seems to make sense that it should, right? And here are some studies that were done about 2 years ago, which simply showed that higher NAFLD rates in patients that had greater amounts of sugar consumption, right? Cut down that sugar, perhaps it gets better. Also, there were higher NAFLD rates in those patients that took sugar-sweetened beverages or things with fructose. And if you go down the cookie aisle, every cookie has fructose in it. Probably the worst thing you can possibly have, but everything, is in that. So that's a start. Cut down the sugars, simple. You would lose weight and NAFLD may improve. We know that if you take sugar in, it increases insulin levels, and studies tell us that high insulin levels are associated with worse NASH histology and fibrosis. So again, we're going to work backwards. If you watch your sugars, your insulin levels will be lower. Maybe you can prevent or reverse the degree of fibrosis that you actually have. So what are the recommendations? The AASLD makes no recommendations regarding restricting sugar. What are the recommendations according to me, which are meaningless? And however, I think there's a good theoretical reason to limit sugars in patients with NAFLD. We talk to the patients about an appropriate diet, and hopefully by limiting sugars and fructose, insulin levels will be lower and it may prove beneficial. But I have no data to support what I said, but it does make common sense. What may be the best diet that you could recommend? Well, in 2019, the Mediterranean diet was named the best diet out there. Right? It's really a good common sense diet. It does not eliminate any particular food group, but shunts patients or people to really a more balanced diet, heavy on fruits and vegetables, fish and seafood, limiting meats, limiting sweets, limiting certain dairies, and limiting amount of alcohol. And you don't really have to go over it. You can tell people to go online, and there are lots of these pyramids and iterations of the Mediterranean diet that they can follow. It's actually been studied in this paper that was published a year ago, comparing a Mediterranean diet to a low-fat diet in patients that were followed for 18 months. Those patients that followed or in the Mediterranean diet arm had significantly greater improvement in the overall hepatic fat content and had a significant overall decrease in risk of cardiovascular disease. And that's important since the most common reason these patients actually die is cardiovascular disease, not liver disease. What about other diets? There may be some evidence that DASH diets, dietary approaches to limit hypertension, are correlated with lower levels of fatty liver. These are very similar to the Mediterranean diets, lots of fruits and vegetables, low-fat dairy foods with fish and chicken, right? Avoiding meats and others. Where there is no evidence out there yet for dieting for fatty liver are things like Weight Watchers or Jenny Craig. They may work and they may be efficacious and people may lose weight, but we don't have any data yet in fatty liver. And all of these sort of fad diets where patients lose weight rapidly tend not to be so effective because most patients, when studied, who go on these fad diets lose a lot of weight, stop the diet, and end up being heavier than before they started. And so they don't necessarily work. We do want to make sure that any diet that you put someone on is actually heart healthy. Because again, these patients die more of heart disease than of liver disease. One of the questions the patients ask all the time is, can I be placed on a statin? I was told that I have fatty liver. The cardiologist doesn't want to put me on statins even though my cholesterols are high. This was published 2 years ago in Hepatology. Again, we know that patients with fatty liver are at greater risk of the development of cardiovascular disease. And we also know through multiple studies that statins are safe and effective to treat dyslipidemia in patients with NASH and NAFLD, even if they have compensated cirrhosis. So these patients can be placed on statins. All right? Very important message to get out there to the community. What about vitamin E? It's probably one of the best studied drugs in fatty liver. It's been shown to be beneficial in non-diabetic adults with biopsy-proven NASH. But it's very important if you're going to start someone on vitamin E, and it's 800 international units a day, that you go over the risks and benefits. It improves underlying histology, but not fibrosis. And there are questions about long-term use in men, specifically because a theoretical increase in prostate cancer in patients taking long-term vitamin E. Vitamin E isn't recommended to treat diabetic patients that have NASH. It isn't recommended to treat anyone with fatty liver in the absence of a liver biopsy, and it's not recommended in patients who are known to be cirrhotic. So very important that you know this. In addition, vitamin E will thin the blood. It works as an anticoagulant. So if you're putting someone on vitamin E and they're going for a dental procedure or other surgical procedure, you need to make sure you tell them to stop it, a few days before. People have tried metformin. It is not recommended. It really has been shown not to work. Pioglitazone was used early. It's actually been shown to improve liver histology in patients with or without type 2 diabetes, in patients who have biopsy-proven NASH. So it can be used in these patients. But again, before you're going to start someone on pioglitazone, you should biopsy the patient and ensure that they do have NASH. What about a different class of drugs, the GLP-1 analogs, which really help with weight loss? Here, there's a lot of excitement. There have not been large trials done just yet. So I think it's too early to just recommend these. But I do think the field is headed towards GLP-1s as being helpful in the treatment of fatty liver. And again, if that happens, it's more likely that a lot of the care of these patients will shift from the GI hepatologists to the endocrinologists, who are at this point much more familiar with the use of GLP-1s than we are. In the past, many patients were put on ursodeoxycholic acid. Studies have shown that that really offers no benefit over placebo. It'll bring the liver enzymes down, but doesn't do anything to the histology. Omega-3 fatty acids, perfectly safe to use in patients that have fatty liver, but hasn't been shown to treat fatty liver. So there's no reason why you can't give it for other reasons, but it's not going to treat the fatty liver that the patient has. Oops. What has been shown to work really well? Bariatric surgery. Earlier on, I showed you an MRI example of a patient that had bariatric surgery, lost a lot of weight, and had a decrease in the amount of fat in the liver from 30% to 3% in as short a period as 6 months. It doesn't matter what type of bariatric surgery, as long as the patient has it and loses weight, and the most common one now being done is a sleeve gastrectomy. So if I summarize the current treatments for NASH before spending a few moments on new therapies, you're going to assess the patient for NASH. If there's steatosis and no evidence of any significant fibrosis, it's really management of the metabolic syndrome and assessing the cardiovascular disease risk. If there's NASH on biopsy or evidence of significant fibrosis, lifestyle modification first. You can consider vitamin E in the non-diabetic female. Pioglitazone is possible. Statins for dyslipidemia, right? And then for those who meet criteria, bariatric surgery. Here's where we stand today. Despite all of the research and all of the stuff we've heard about, nothing is yet approved. And again, diet, exercise, and weight loss. Can't sort of overestimate that. So in the last few moments, let's talk about what's emerging. And it's really like a snail coming out of its shell, very carefully and very slowly, many times being beaten back in, if you will. There are lots and lots and lots of different medications now being trialed for the treatment of fatty liver. We've lost a little bit of time on many of these studies because many studies were shut down during the COVID era, but they're beginning to open up and we'll get some more information. I'm going to highlight a few things. Most of you have heard about obeticholic acid, available and approved for the treatment of primary biliary cholangitis, but a lot of excitement was around this regenerate study, a long-term treatment of patients with fatty liver whose endpoint was a decrease in fibrosis. In a preliminary analysis, this trial actually met that endpoint with a decrease in fibrosis of greater or equal to 1 stage with no worsening of NASH at this interim analysis, which was 18 months. Hard to read, but the drug was safe. Across the different arms, there were similar serious adverse events. There was more pruritus in the patient group that received the obeticholic acid, which one would expect with this particular medication. Oops. But unfortunately, this drug, we're still waiting for FDA approval. Just recently, the approval was deferred. I'm assuming that for want of more information, and so we wait. Liraglutide, which is a GLP-1 agonist, was used in a trial looking in overweight patients with NASH, the so-called lean study. Numbers of patients were very small, less than 50 in an entire study. But what you can sort of see in a trend here is that the patients that got liraglutide did better than those who got the placebo, with a higher incidence of resolution of NASH, improvement histologically by decreasing of the ballooning and inflammation, improved fibrosis. And so, again, one of the reasons why I think GLP-1 agonists need to be further studied and may end up being a part of a multi-drug regimen that we use. The drugs were safe, with nausea, diarrhea, and headache being the most common. Interestingly enough, there was nasopharyngitis no statistical difference between that and placebo. It just amazes me as an aside how commonly reported nasopharyngitis is in almost every study. We saw this in the hepatitis C studies. We're seeing it now. I guess people get this quite commonly in the course of a year. So if we look at fatty liver and think about what we've discussed, it's a tremendous problem. We talked about the problem in the U.S., which is about a third of the population, but it's close to a third of the world's population, with certain areas such as the Middle East and the Gulf being much greater than other areas. But South America and North America are problematic. We truly don't understand its pathophysiology, which is probably why we haven't been able to develop single therapies. There are multiple risk factors for it, but the most common are obesity and diabetes. It has significant morbidity and mortality, which is only going up and going up pretty rapidly if you look at transplant centers and their evaluations for patients with this condition. It's very important that we diagnose and stage these patients. Screening is the difficult question. Who do we screen and whose guidelines do you believe? But it is important when someone has been found to assess for degree of fibrosis, remembering that liver enzymes aren't the end all, and patients with normal liver enzymes can have advanced fibrosis or even cirrhosis. The current treatments are not medication-based for the most part. They're lifestyle-based. Diet, exercise with associated weight loss to improve the underlying liver issue, but equally important, to decrease risks of having problems related to the cardiovascular system. And there's a lot of work, obviously, being done to develop new therapies. Nothing is close. Nothing is there yet. Probably we will end up taking multiple drugs with lifestyle modification, and it'll be interesting once things are approved to find out who will pay for these probably new, very expensive drugs in the future. So with that, I'm going to end with a very old, at this point, cover from The Economist, where there was a review of what's happening in the Western world or the developed world regarding weight gain. So please take action. Healthy food choices are very important, and regular physical activity important, so we can stop the evolution, if you believe in evolution, from thin to not so thin anymore. Thank you. That's it.
Thank you, David, for that excellent review of NASH and state of the art. The Q&A we're going to hold at the end, so please hang on to your questions. David mentioned the snail's pace of therapeutics in NASH, and it reminded me of an old story. These two snails are walking towards each other in a path, and neither one will yield to the other. A slug is coming by, and the two snails get into a fist fight, and they're going at it with each other. Police come to break it up. They turn to the slug and say, "What happened?" And he says, "I don't know. It all happened so fast." So. The next talk is by Dr. Robert Brown. He's an endowed professor at Cornell. It's going to be covering the complications of portal hypertension, management options for hepatic encephalopathy, thrombocytopenia, and hepatorenal syndrome. Dr. Brown.
Quick podium wipe, and we're ready to go. So this is a combo of Brown and Brown. Kimberly Brown will join us 2/3 of the way through, and then we'll do question and answers. And we're going to handle some common problems in portal hypertension as told by through a single case. Is there a particular button that I should push? Here's our disclosures. So this is our patient. We'll call him John or David. He's a 51-year-old man who who is admitted with decompensated alcohol-related cirrhosis. It's probably not his real picture because he'd have much more muscle wasting, and it doesn't look like that guy has any ascites. But over the last 6 months, he's required large volume paracenteses with increasing frequency, and he comes in a little bit altered, hemodynamically stable, stigmata of cirrhosis, moderate to large ascites, and significant peripheral edema. He's taking furosemide, spironolactone, propranolol, esomeprazole. He takes some ibuprofen every once in a while for joint pain because he was told to avoid Tylenol for liver toxicity, and sildenafil as needed. We don't know how frequently that is. I don't usually ask those kind of questions. He has no history of injection drug use, and he stopped drinking about 1 year ago, conveniently. He's has maybe a low-grade temp, resting heart rate of 65, low blood pressure at 90/65. By the time you see him, he's actually alert and oriented without asterixis. His lungs are clear. He has stigmata of cirrhosis with spider angiomata and pulmonary erythema, but no caput. He has moderate ascites. He has splenomegaly, normal bowel sounds, and some peripheral edema. His white count is low at 2.7. His platelets are low at 61. Hemoglobin is low at 10.9. Albumin is really low at 1.9, typical for an alcoholic cirrhotic. Very low albumin in the setting of difficult to manage ascites with minimal hyperbilirubinemia, 2.1. His AST is higher than his ALT, as we see in many patients with alcohol-related cirrhosis. His creatinine is 1.76 for a MELD score of 27. If you add in his low sodium, his MELD NA is 27. Hepatitis B and C are negative. His iron saturation is 40%. An ultrasound is performed, and I think with a creatinine of 1.76, that would be your test of choice. Try to avoid doing CTs with contrast in this setting. And it shows a small nodular liver, an enlarged spleen, no mass lesions. The portal and hepatic veins are patent, and he has a large amount of ascites. So the next step is a paracentesis, and if you thought it was something else, you were not correct. All patients who come in with a decompensated state and large ascites should have a paracentesis to rule out spontaneous bacterial peritonitis, regardless of abdominal pain, regardless of white count, and regardless of fever. And he has one, and it shows a high serum albumin ascites gradient, which is what you'd expect, consistent with portal hypertension. We would subtract the serum albumin from the ascites albumin from the serum albumin. If that number is over 1.1, this is portal hypertensive. We would also get a white count and diff on the fluid, and his white count is 982, 70% polys, so about 800-ish. And that would be 700-ish. That would be consistent with spontaneous bacterial peritonitis. Any neutrophil count over 500. No, over 250, way above that. So what are our next steps in therapy? We're going to treat spontaneous bacterial peritonitis with antibiotics and 25% albumin. 1.5 grams per kilo the first day, 1 gram per kilo the third day, and then we have to deal with his acute kidney injury, which may be due to SBP and may be due to hepatorenal. So when do we perform a TAP in cirrhotic ascites? All the time, meaning when you first diagnose them and anytime they're hospitalized and anytime they deteriorate while they're hospitalized. And some people say, well, I tapped them 5 days ago and it was negative. But that tap could have caused a problem. So you have to think about secondary peritonitis from your last tap. So All you need to diagnose SBP is a poly count above 250. So you need a cell count and a diff. Cultures are helpful, but not necessary for diagnosis. They will be positive in the minority. The treatment is antibiotics for 5 days. Some people retap at 48 hours to see that the white count is coming down by 50%. Though if the patient's doing well and is clinically improving, that's not necessary. And I told you the albumin dosing. It is clear that anyone who has had spontaneous bacterial peritonitis should get secondary prophylaxis. And daily prophylaxis has been shown to be superior to weekly prophylaxis. So whether you use a single strength Bactrim daily or Cipro or Levaquin daily is up for debate, but weekly Cipro, which used to be popular, has been shown to be less effective. Primary prophylaxis is far more controversial. There is data showing that if you have low albumin ascites, very low, with a higher MELD score, that it may improve outcome. However, most of that data is from countries that have very low rates of antibiotic resistance. In New York, where we have very high rates of antibiotic resistance, here in New Jersey, where I suspect it's the same, the risk benefits have to be considered very carefully. And we don't do a lot of primary prophylaxis in our program, but it's something we could discuss if you want during the panel. So now let's turn our attention to acute kidney injury. And we're going to go through these types of things because acute kidney injury is a major cause of morbidity and mortality in our patients with portal hypertension. So acute kidney injury has changed from our prior definition, which required a larger increase and you to be above a creatinine of 1.5, to recognize that in patients with cirrhosis, muscle mass is impaired, baseline creatinines are lower, and thus, and often not known. So the old criteria was a 50% increase in serum creatinine. Now it is either an increase in 50% above baseline or 0.3 milligrams per deciliter within 48 hours after admission if you don't know the baseline. So, and then once you meet that criteria, we can then stage it 1, 2, and 3. And those are pretty simple. 1 is 1.5 to 2. 2 is 2 to 3 times their baseline. And 3 is greater than 3 times their baseline or on dialysis. Now, do these stages mean something? And the answer is yes. So if you look at patients who have stage 1, you can see that there is a cutoff that the creatinine of 1.5 is the place at where outcomes begin to be worse. But that doesn't mean we should not pay attention to those that have a 30% increase that don't meet that 1.5 because we want to treat them before they get there. But you can see that if you get down to stage 2 or stage 3, a doubling from their baseline, which could be a creatinine of 1.8 to 2 if they started out at 0.7 to 1. The survival is markedly impaired. And so we have to be very attuned to 1, what is the baseline creatinine? And 2, what are the changes, and intervene as early as possible. So when I was taught about HRS as a trainee, I was told this was really just a problem of renal perfusion, that with portal pressure, the kidney wasn't perfused well, and as a result, the patient was oliguric, and if you just reverse that, it would get better. But it's recognized that this is actually a multifactorial state marked by systemic vasodilatation, splanchnic vasodilatation with inadequate cardiac output to make up for it. This, combined with portal hypertension, translocation of bacteria and then systemic inflammation is not able to be met by the cardiac output. So though the cardiac output in cirrhotics is increased, it is inadequate for the volume demands, and that leads to low effective blood volume. And then the kidney does respond to that low effective blood volume in its characteristic way. Afferent arteriolar vasoconstriction, low renal blood flow, absorb all the salt and water that you can to try to preserve blood volume. But of course, the patient is massively volume overloaded. And the more you give them, the more they hold on to. And we have to reverse that process to reverse HRS. And over time, that afferent arteriolar vasoconstriction leads to ischemia to the tubules and ATN. So oftentimes you can have ATN and HRS, even though the traditional thinking was you had to differentiate ATN from HRS. Early HRS can be pure. Late HRS usually has a tubular element as well, which can make diagnosis challenging. So when we think about AKI and cirrhosis, we really are thinking about three things. 2 pre-renal, which is true pre-renal, hypovolemia from diuretics, bleeding, diarrhea, LVPs without albumin support, and hepatorenal, which is pre-renal physiology in the setting of U or hypervolemia, and ATN and interstitial nephritis, because primary glomerular nephritis and obstructive uropathy are extremely rare. So when is it HRS? Well, the first, it is still a diagnosis of exclusion. So first, you have to have AKI. 2, you have to not respond to a volume challenge, usually defined as 2 days of withdrawing diuretics and plasma expansion with albumin. 1 gram per kilogram of body weight, 100 grams max. So if they weigh 100 kilos, don't give them 100 and 100, give them 50 and 50. And after that, if they still have volume, low albumin, titrate the dose. I personally titrate to the serum albumin. I give it about TID until the serum albumin's above 3 or 3.5 and then cut back. They shouldn't have shock. They shouldn't have nephrotoxic drugs, which is challenging. Our patient, John or David, had taken non-steroidals recently. Is that enough? Well, I would say we have to see. But they should, and you can have a little bit of proteinuria, but you shouldn't have massive proteinuria. So this is a clinical diagnosis and remains that way. So when we think about hospitalized patients with cirrhosis, most patients who have AKI, most patients with renal impairment, it is AKI. And that's about 20% of hospitalized patients with cirrhosis. And you can think of it as 2/3, 1/3. 2/3 will be pre-renal, 1/3 will be renal, meaning usually, as I said, AIN or ATN. And post-renal or obstructive, extremely uncommon, less than 1%. And then of the pre-renal, it's 2/3, 1/3. 2/3 volume responsive or true pre-renal, 1/3 HRS. But that still has 1/3 of 2/3 or 2/9 of 20% of patients. It's not an insubstantial number of patients who are going to come in with HRS. And given its poor prognosis, early recognition is really quite important. So what should we do? First, stop nephrotoxins. So we would stop ACE inhibitors and vasodilators if he's on them. ARBs and ACE inhibitors, which are frequently on our diabetic NASH patients with renal impairment. Not a good idea with portal hypertension. He probably should not be on his PDE5 inhibitor. Withdraw diuretics. Hard to do sometimes when patients have massive volume overload. I see patients getting more diuretics, IV diuretics in this scenario, when we should withdraw them and do large volume paracentesis as needed with albumin. If they're having massive diarrhea from lactulose, stop or decrease. With this low of blood pressure, give them a holiday from their beta blocker. We talked about IV albumin, and if that fails after the 2-day holiday, the next step is a vasoconstrictor. So this is the IV albumin, and so we use IV albumin to maximize oncotic pressure and intravascular volume. And then we give a vasoconstrictor to constrict both the splanchnic bed as well as usually the systemic bed. The typical has been midodrine and octreotide. However, it is very, very poorly effective. Most of the Cochrane analysis said it is no better than placebo. Yet, getting a patient into the ICU to get norepinephrine or IV vasopressin can be a challenge. So I'd be lying to you if I said I didn't use midodrine and octreotide. I do. But whenever possible, we should probably be using norepinephrine or vasopressin. And ex-US, the first line of therapy is terlipressin, though it is not available in the United States. So if you read the European guidelines for HRS, they say use terlipressin first. And of course, here we cannot. So what is terlipressin? Terlipressin is a synthetic amino acid peptide that is a prodrug of vasopressin. It has constrictive activity via the V1 receptor with minimal activity on the V2 receptor, but some. It then causes splanchnic vasoconstriction to decrease portal pressure. And that increases the effective blood volume by decreasing splanchnic pooling and has been shown to decrease renin and angiotensin production, improving renal vasoconstriction and improving serum creatinine. It does have some V2 activity, which can lead to hyponatremia, and that needs to be monitored on therapy. Though in general, if urine output improves, the hyponatremia is less than what we see when the patient is oliguric. So the CONFIRM trial was recently completed, submitted for FDA approval, and because the FDA, like the rest of the country, is in a COVID crisis, they did the same thing as they did to obeticholic acid, which was give them a complete response letter asking for more data. I don't know whether they really wanted more data or they couldn't have a meeting, so they said this was the easiest. It looked to me a little bit like, you know, that Heisman maneuver. You just push it down the road a few months and then we'll see what happens. Because this was the largest trial of a drug that is approved across most of Europe and the world. And it had a positive outcome in that terlipressin was shown to reverse HRS, which was defined as a creatinine that went down to less than 1.5. Twice as frequently as placebo, which was standard therapy. Many of these patients had already failed midodrine, octreotide, and albumin, so they were just getting basically albumin. And it was durable, meaning that they stayed that way out to the end of the study, which was day 30. And so 30% stayed that way, whereas on the placebo, 85% did not have a sustained HRS reversal. There were adverse events, but they were exactly what we would expect from a vasoconstrictor and no worse than, say, vasopressin or noradrenaline. But we're going to have to wait for whether it gets approved. Currently, it's not available in the United States. But in Europe, it is used on the floor outside of the ICU with a peripheral IV, which would be a big advantage to our patients. So what happens? Well, we give him some albumin and we treat him with antibiotics. His creatinine gets better, but his platelets drop. And now they're 31,000 and his belly is out to here. We're not giving him any diuretics and he needs a tap. And the radiologist doesn't want to do any more tapping. He recommends a TIPS, but the radiologist says, I can't do a TIPS. His platelet count's 31,000. Matter of fact, I don't even want to do an LVP. His platelet count's 31,000. So now what? Poor John, David. This is a slow clicker. It's like it's somewhere in between the snail and the slug. So thrombocytopenia is common. Matter of fact, I see plenty of patients with cirrhosis who have been followed for thrombocytopenia with it being called ITP for many years often. It's estimated to affect up to 70% of patients with chronic liver disease. It worsens the worse their portal hypertension, and it really impairs their care. It doesn't really impair their quality of life. Bleeding is pretty uncommon, but they're denied procedures, elective surgical or diagnostic procedures. They get a colonoscopy and big polyps are left behind to grow into whatever. It has been shown to relate to mortality, not just because of bleeding, but probably because it goes with the severity of portal hypertension. And the worse your portal hypertension, the worse your outcome. And so all in all, it decreases quality of life and decreases quantity of life. And everyone knows of the patient who says, I can't lose weight, doc, because my knee hurts, and no one will fix my knee because my platelets are low. So if we had a good therapy, it would be helpful. And why do they get it? Well, we always thought about the big spleen. They're sequestered in the big spleen. And maybe they'll come out if you need them. But actually, it's more multifactorial. You do see in many patients bone marrow suppression due to alcohol, usually, sometimes other drugs, azathioprine that we may be treating their disease with. And we see increased destruction due to fibrinolysis from their liver disease, antiplatelet antibodies, particularly if we give them platelets. But also we've been shown that TPO production in the liver is too low for the degree of thrombocytopenia, just like renal failure, where EPO levels are too low for their degree of anemia. So the traditional standard has been platelet transfusion. And we know that in patients who have low platelets from bone marrow transplants or other chemotherapy, that platelet transfusion prevents spontaneous bleeding. And certainly with active bleeding, platelet transfusion is still the standard. However, platelet transfusion in cirrhotics doesn't work very well. One, they get refractory, both because they go to the spleen where the other platelets are. This isn't a lack of making. This is a lack of function. And so these are very difficult. And anyone who tries to arrange a platelet transfusion prior to a procedure in a cirrhotic knows how hopeless it is. You arrange it, and then the anesthesiologist wants a platelet count. By the time you get the platelet count, the platelets are already back down to their baseline. So platelet transfusions, to me, peri-procedurally treat the doctor, not the patient. And if you don't believe it now, ask me. I'll ask you again in about 4 slides. So most patients with cirrhosis require 1 to 3 procedures annually. Some of them are easy to manage. Some of them are hard to manage. Some of them we've chosen to do despite the risk, like banding of varices. But when people say, well, I band all the time with a platelet count of 20, I say, yes, but wouldn't you be happier if they had a platelet count of 50? And anyone who says no is kind of not telling the truth. And so the only option previously was platelet transfusion because the prior thrombopoietin analogs were not approved for use in this indication. But there are thrombopoietin receptor agonists that act in a non-competitive manner. They bind differently from TPO, and so they don't block native TPO. And two of them are approved for the use in chronic liver disease and thrombocytopenia, and they are avatrombopag and lusatrombopag. And both of them showed pretty similar results. So this is the data. The study designs were similar. Platelet count less than 50,000, a procedure being planned for which platelet transfusion was desired. And then you either got drug or placebo. And then after the drug therapy, usually around day 9 or 10, if your platelet count was less than 50,000, you got platelets. And the procedure, if it was above 50,000, just got the procedure. And the end point was having a platelet count above 50,000 without a platelet transfusion for this study and without a platelet transfusion or bleeding for the lusatrombopag study. And what you can see is avatrombopag has 2 doses. It comes in 20 milligrams, so you either give 2 pills or 40 milligrams if the platelets are between 40 and 50. 3 pills, 60 milligrams if it's between below 40. And what you can see is compared to placebo, about 90% of patients got a platelet count above 50,000 compared to 40% with placebo, and more than almost triple the number did it when the platelet count was lower. If you look at the rate of just getting above 50,000, those are even a little bit higher. But probably better than the percentage is the time course of platelets. And what you can see is that when you administer this at either of the 2 doses, you get about a doubling of the platelet count. And most of the patients go above 50,000, and then they slowly settle back down. The peak is on day 10. You dose it from day 0 to day 3. You do the procedure a week later, and you can see you have a consistent platelet count. And then it slowly settles back down to baseline by day 30. The other thing to notice is look at the dotted line. That was the placebo group that got platelets. And look at how high their platelets went, i.e., not at all. So to me, I would either use a drug like this or placebo, meaning nothing. And for lusatrombopag, the endpoints were a little bit different, which was no platelet transfusion or rescue therapy, meaning something administered after the procedure, either prophylactically or treatment-wise for bleeding. And what you can see is over double the rate with lusatrombopag compared to placebo. But if you look here, 65% got an increase in platelets of more than 20,000 and got to over 50,000. And when you look at the pharmacokinetic pharmacodynamics, it's very similar, has a little bit of a slower uptake. That may be a disadvantage, but also a slower downtrend, which may be an advantage. But you once again see a 3 to 4 day window at the top of the platelet count range, right around also day 10. And then it slowly returns to normal by day 30. And so if your procedure has to be moved a little bit, you can. If you want to do a second procedure after day 10, on day 17, you still can. So these, I think, are really a big advantage for our patients who need invasive procedures. And once again, you can see in the patients on placebo, platelet transfusion minimally increases platelets. You can see that little blip in the mean platelet count on day 10, the day of procedure, and it really doesn't stay even a day. So I'm now going to introduce my partner in crime, Kimberly Brown.
Hi, I'm Dr. Kimberly Brown. Hi, I'm Dr. Kimberly Brown. I am following Dr. Brown, and I want to thank him for an excellent introduction. It's hard to follow Bob because even though we're related, he's a much better speaker than me, but we'll try to do our best. So here's our patient again, and the hospital course is as follows. Dr. Brown has now fixed his platelet count. It's up to 120,000. His kidney function is good. Otherwise, he's stable, and he undergoes a TIPS without complication by radiology. He's discharged, and 2 weeks later, the patient is readmitted after he's found wandering in his house, and he appears to be confused. On admission, he's afebrile, he has a stable heart rate and a good blood pressure. Neurologically, he has some asterixis. He's oriented, but only to person and place. He has minimal ascites, normal bowel sounds, and on examination of his extremities, he has no residual edema. Here are his medications currently. He's on esomeprazole, 40 milligrams daily, and sildenafil as needed. He does occasionally take acetaminophen with codeine for some ongoing joint pain. He undergoes an abdominal ultrasound. His liver is small and nodular. He has an enlarged spleen, and he does continue to have some mild and moderate ascites, but remember, he has no lower extremity edema. He is checked to make sure that his TIPS is still patent, and it appears to be patent on ultrasound. So how do we grade hepatic encephalopathy? Well, typically we use what are called the West Haven criteria. These are described here. West Haven criteria grades encephalopathy from 0 to 4. 0 and 4 are the easiest. 0 is no detectable abnormalities, and 4 is coma. But patients can progress through these grades. Grade 1, patients have some degree of unawareness. They may have some anxiety, be mildly euphoric. Their attention span may be shortened. They may be mildly lethargic or apathetic. On grade 2, patients can become disoriented to time. They may have some personality changes or inappropriate behavior. And then as things progress to grade 3, patients become somnolent. They can become stuporous. They remain responsive to stimuli, but they are very confused with gross disorientation to questions. And when we characterize these stages, you can see on the right, the stages that we just described, 1 through 4, these are what we consider to be overt HE stages. These would be stages that you or I could clinically diagnose in a patient on presentation. But you see, prior to this, there appears to be an ongoing spectrum, and there is a group of patients that may have what we call covert or minimal HE. Categorization of this degree of change is often arbitrary and does vary pretty significantly between raters, and it's often suggested that this would be a stage that patients would require specific testing to make a diagnosis. There are multiple precipitating factors, as we know, for HE. Increased ammonia production, and this can occur from GI hemorrhage, excessive dietary protein, electrolyte imbalance in patients on diuretics, constipation. But portosystemic shunts, either spontaneous or iatrogenic, and in this case, our patient has undergone a TIPS, so we've now created a portosystemic shunt, but these can occur spontaneously in the abdomen as well in patients with advanced liver disease. And then certainly other things such as drugs, opioids, benzodiazepines, anything that can act centrally, anything that can sedate a patient can precipitate an episode of HE, and certainly infections, one of the more common ones being bacterial peritonitis. And then malignancy, especially in patients who have involvement of the portal venous system and potentially have developed portal vein thrombus as a result of tumor progression. So our patient on admission, here are his laboratories. He has a white count of 3.4. His other laboratories are essentially stable, somewhat unchanged. INR's 1.8, no big changes from prior. And then the question always becomes, do you want to get a serum ammonia? So just as an aside, I never want to get a serum ammonia, but I always have a serum ammonia because somebody has already checked it. What is the role of ammonia testing in HE? Quite frankly, what I try to teach our fellows is that if you're going to do a test, you should utilize the information in some fashion to help the patient. Ammonia testing doesn't help you in any way. If the ammonia level is high and the patient is completely normal and conversant, what are you going to do? You're probably going to send them on their way. If the ammonia is low and they're in a coma, you're probably going to treat them for HE. So it doesn't really help guide you in your testing or your treatment. And in fact, when you look at the guidance documents, they suggest that increased blood ammonia alone does not add any diagnostic, staging, or prognostic value for HE in patients with chronic liver disease. Now, if you did have a normal value and were still concerned, then diagnostic reevaluation would be appropriate. So what are some of the risk factors in our patient now that he's had a TIPS? So we can look at several variables: age, gender, what the patient's MELD was prior to TIPS, whether the patient had a history of HE, and whether or not he used PPIs. And we recognize that there are several factors. The two that we most commonly call out are the age of the patient and the presence or absence of HE prior to undergoing a TIPS as the largest risk factors. But note the odds ratio in a multivariate analysis in patients following a TIPS that were on PPIs. And this is an interesting concept, and largely because there have been two large meta-analyses looking at PPI and the associated potential risk of HE in patients with advanced liver disease. Now, this was a retrospective study looking post-TIPS, but there is some suggestion in the literature that PPI use may in fact increase the risk of HE in the patient population. One of the most important things, though, to recognize from that information is the fact that in those studies it was suggested that as many as 40 to 70% of patients on a PPI did not actually have a concrete a diagnostic reason for the PPI. So certainly, whether you believe the data or not, taking a patient off a PPI that was never indicated is probably a good thing to do. When we look at the pathogenic mechanisms of HE, we can draw pretty pictures, but ultimately we don't really know what the answer is. But the suggestion that factors involved in patients who have advanced liver disease cross the blood-brain barrier, causing astrocyte swelling, causing some relative increase in intracranial pressure, all of this being driven by inflammation, increasing cerebral blood flow. And when we look at this, there are several factors that have come into play: pro-inflammatory cytokines, nitrous oxide, and oxidative stress as potential pathogenic mechanisms for the production of HE. But another interesting thing to consider, and this may get back to the use of PIs, which are the fact that when you have a leaky gut, which occurs in patients who have liver disease, so this is an example from patients who have alcoholic liver disease, but those bacteria can translocate across the membrane. You can get bacterial byproducts, including LPS, into the portal system, which can then go to the liver and activate a number of different pathways, producing cytokines and otherwise developing this inflammatory condition that we see in patients who have advanced liver disease, particularly alcohol. And when we look at the odds ratio for readmissions, so this is looking at patients and considering their original reason for admission, whether that be ascites, a variceal hemorrhage, encephalopathy, hepatorenal, hepatocellular cancer, and looking at the odds that they will come back within a 30-day period, you can see that, in fact, hepatic encephalopathy, the odds ratio of readmission is the highest compared to those other complications of liver disease. And I think we often disregard the implications of encephalopathy and the significant impact it has on patients' morbidity and mortality. And certainly here you can see on hospital readmission rates. So we have several current therapies and past therapies that we've used for HE. These include lactulose, rifaximin, neomycin, metronidazole, vancomycin. I won't talk about the last three. These are all antibiotics, and currently none of them are approved for use in encephalopathy. And in particular, neomycin, which I had used when I was training, there is really contraindication to utilizing this because of the associated and potential renal and ototoxic risk that this antibiotic has. But we are left with lactulose. This is a poorly absorbed disaccharide. It has been shown to decrease blood ammonia concentration and can prevent and treat portosystemic encephalopathy. And rifaximin, which is a non-aminoglycoside semi-synthetic non-absorbed antibiotic. And this has been shown to reduce the risk of overt hepatic encephalopathy recurrence in patients over the age of 18. So we're back to our patients now. He gets several doses of lactulose. His mental status clears up. And as with many of our patients, within 48 hours, he's alert, he's oriented, and he wants to go home. So now the question is, what do you do? What do you recommend to this patient upon discharge for long-term ongoing management? So here's the study looking at rifaximin, and this was published now 10 years ago in the New England Journal. And what this study did was, in a randomized controlled fashion, was to compare rifaximin to placebo in patients who had had documented episodes of HE, and looking to see the time point or the proportion of patients who had breakthrough, or as this slide awkwardly points out, without breakthrough, over a period of follow-up. So here you have rifaximin, 78%, placebo 54%. And what this shows is that in patients who were receiving rifaximin, 78% of those patients were free of recurrent HE over the follow-up period, significantly higher than the patient population receiving placebo. And very similar to this, and very important, this was a secondary endpoint. This was looking at the time to the first HE-related hospitalization. Remember, I just showed you that the odds ratio for hospital readmission within 30 days is highest in patients who were discharged for encephalopathy. And what you can see here is that the patients without HE hospitalization, so the higher bar is the better bar. So over the period of follow-up, 86% of patients on rifaximin were free of hospitalization in the follow-up period, as compared to 77% of those patients on placebo. So what rifaximin was really shown to do was to decrease recurrent HE in a higher percentage of patients as compared to placebo, and there was a longer period of time before they came to the hospital with a recurrent episode of HE. So how do we prevent recurrent HE? Well, here are the practice guidelines from the AASLD, and we see that lactulose is recommended for prevention of recurrent episodes of HE after the initial episode. Rifaximin is an add-on to lactulose, and it is recommended for prevention of recurrent episodes of HE after the second episode. Why after the second episode? That was the way the clinical trial study was performed. Routine prophylactic therapy with lactulose or rifaximin is not recommended for the prevention of post-TIPS HE. This is an important point, could be a board question, because again, we had a patient who had had a TIPS. He wasn't particularly old and he didn't have a prior history, but some people would have thought maybe they should have put him on lactulose or rifaximin on the way out the door, but that is not currently the recommendation. And under circumstances where the precipitating factors have been well controlled, so this may be a patient who had an infection and deterioration or a decline in liver function or nutritional status, if these have improved, it is suggested that prophylactic therapy could be potentially discontinued. So what about patients with minimal HE? I'm going to show you a couple of slides because this is an area that people are starting to look at. This would be the covert HE patient or minimal HE patient. Is there a way that we can potentially decrease the chance that a patient will have an overt episode of HE? So here are several pharmacologic interventions looking at lactulose, LOLA, rifaximin, probiotics versus placebo. You can see that the quality of evidence in all of them is low to moderate. But if you look at the odds ratio, you can see that rifaximin as compared to placebo seems to have the highest odds ratio in terms of delaying or preventing an episode of overt HE in a patient who has a history of minimal HE. And then if you look here, again, this is just in graphic form, you look at the odds ratio on the right and you see that rifaximin has the highest odds ratio in terms of, again, delaying or treating minimal HE. So we're back to our patient again, and if you believe the evidence I just showed you, it suggests that we should put this patient on both rifaximin and lactulose to treat minimal HE and prevent recurrence of overt HE. We should consider discontinuing his esomeprazole in large part because it's not clear why he's on it. There was no indication that we could identify, and it may increase the risk of HE and infections. And then furthermore, we can discontinue his propranolol as the TIPS now replaces the need for beta blockers and could potentially lower his blood pressure. And of course, if he doesn't need his diuretics any longer, we would like to send him home without them. So our our take-home messages from both Dr. Brown's and Dr. Brown's presentations are that patients with cirrhosis are at increased risk for development of minimal HE. This can compromise the quality of life. Treatment should include both rifaximin and lactulose in the majority of patients to prevent recurrence of overt HE. The treatment of AKI-HRS includes albumin and agents to increase splanchnic vascular resistance, such as terlipressin, and thrombopoietin agonists increase platelet counts prior to invasive procedures and can be used in patients with severe thrombocytopenia undergoing invasive measures or procedures. Thank you very much.
This Q&A will last about 20 minutes, hopefully. Then there'll be a 15-minute intermission before the rest of the presentations, which are going to be virtual for this afternoon. And those speakers apparently are going to introduce themselves. So we're good. Okay. So the first question that I'll ask Dr. Bernstein to comment on, but open, is NASH reversible with weight loss alone? I know you mentioned it in one of your slides. Perhaps you could just expand on that.
The question is NASH reversible with just weight loss alone? And the answer to that is yes. As I said, if people lose significant weight, 5 to 10% of their body weight, that can be reversed. Exercise helps with that weight loss and helps overall with cardiovascular disease reduction risk. But certainly if people lose weight, NASH resolves, and we know that from the studies in bariatric surgery.
Yeah. The other question is, perhaps Bob can answer, does lactulose concomitantly get used with rifaximin, and when would you not?
you want to answer that, Kim?
Yeah, I'm here. How are you? Can you hear me?
Oh,
Yes.
yes. It's like the
Okay.
virtual debate.
Yeah,
Well-
it's a good question. No, if you remember the study with rifaximin, the most of the patients were actually already on lactulose at time of entry into the study. So oftentimes what you'll see in the community is you'll see lactulose with rifaximin added on. I have used rifaximin in the absence of lactulose, but we have to remember that constipation, low stool volume of any sort for any reason can actually contribute to worsening HE. So I often do use them in combination. Some patients don't tolerate lactulose or don't take it, and then rifaximin is often what they're taking alone anyway.
I agree. I think that, our therapies for HE are inadequate as is. And so using a low dose of lactulose to minimize side effects with rifaximin for anyone who has really significant HE is probably the best route.
Yeah, I would agree. We like to optimize the patients if possible by having them take rifaximin. And then for those that don't need lactulose, and many don't, they have the lactulose at home, what you call breakthrough. If they start having symptoms, then they can start taking them.
Curious, some of the studies show that readmission rates, 30-day readmission rates for HE are as high as 57%. Do your hospitals do anything to try and cut down that readmission rate?
Yeah, most of that incredibly high readmission rate is related to non-adherence or non-compliance with the medications that they've been given, in particular rifaximin. We tried a program for a short time to give the patients rifaximin for 1 week in the hopes that they could then follow up with someone who can write the prescription. But it didn't work because couldn't get people in. People could get into the appointments within a week, but then they had to go through the process of prior authorization for the rifaximin, and it didn't work. So we stopped that. I don't know what you guys did.
So Vinod, we try to do the prior authorization procedure while hospitalized because that's really the limiting factor for patients to obtain medications on discharge. So we actually do the prior auth prior to discharge. The patients that we have the most challenge with are the patients who are transferred in from elsewhere. So their primary care is 2, 3, 4 hours away from us. So they can typically, in that case, get their first amount of rifaximin, but if they don't follow up with us, then subsequently they're stopping it.
This is a question I think everybody can address. What are the indications for liver biopsy in the setting of NAFLD? How do you decide, given the third of the population is obese?
I think it's uncommon now, and it will be less common in the future. Currently for many of these clinical trials, they require a liver biopsy. But I think that as MR and other forms of elastography become more standard, you'll be able to stage the patients without. So we use them when the staging is equivocal, or when after, we're working away at trying to minimize risk factors and we can't get the liver test to normal and the patient needs a biopsy to show them that they have a serious problem.
Yeah, we also don't use biopsy all that much. We do it now for patients who are required in clinical trials. Also, when there's some sort of discordance between the various tests, I don't know, FIB-4 shows that there's cirrhosis, or transient elastography says none, or vice versa, just to get a better idea or handle of what's going on. Especially when one test shows cirrhosis and one doesn't, patients tend to want to know, and that's the reason we do many biopsies.
We'll switch from NASH for a minute. Dr. Brown, do you have any experience with HRS that you can comment on the use of vasopressin or norepinephrine? Your experience, please.
We used to use a lot of vasopressin. Now we use more norepinephrine. in patients who we can get into the ICU for it. I think it works pretty well. You don't need a high dose. You just need to increase the MAP by about 20 to 20 points. Some say 15. And you can titrate it to urine output. Most of the large meta-analyses have shown them equally effective to terlipressin, but terlipressin obviously has the advantage of being easier to use and you can use it on the floor. But I think the key to all these vasoconstrictive therapies is they've been shown to work well in early stage HRS, but not well in late stage HRS. So if you wait till the creatinine is 4 and they're peridialysis, you're not going to make any difference. And that's usually when you can get the patient into the ICU. And so we push pretty hard in patients who aren't responding to midodrine octreotide after a day or two to put them in the ICU, try the noradrenal. And the only problem is that they tend to have a high relapse rate when you stop. So it has to be a bridge to something. And that something is either a liver transplant, ideally, or if they have a potentially recoverable insult, meaning either an infection that you're treating, acute alcoholic hepatitis that may get better with abstinence.
How do you handle patients who have HE, and when do you refer them to a transplant center? Are there recalcitrant patients, and how does somebody decide when to send them over?
So I guess I'll take that one since everybody seems to be looking toward the monitor. I don't know. I can't really tell what's going on there. But so I think that the one point I would try to make is that I think we underestimate the morbidity and mortality associated with HE. If you look at some of the data, it suggests that, we all think everybody dies once they have a variceal hemorrhage, but actually the morbidity, mortality in somebody with refractory HE is worse. So I would highly recommend and am very happy to see patients at the first sign. I don't think this is something that should have ongoing treatment without assessment for transplantation. Now, not all these patients will be a candidate for transplant, but I think they should be seen and evaluated at a transplant center once they've developed HE. I don't think that there are patients that we should continue to manage in the absence of that consideration.
Pioglitazone, it can actually induce weight gain. So how does it help in NASH?
So that's absolutely true. One of the adverse of those side effects of pioglitazone is weight gain. I think you have to choose the patient population you're going to use it in carefully. Its exact mechanism of how it works, I honestly don't know. It obviously improves insulin resistance, and so probably that would help. But it has been shown to be effective in certain subsets of patients, as we've talked about earlier. I have to admit, I don't use it very often, but many of the endocrinologists actually do.
The role of fructose in fruit, how important is that when it comes to NASH?
Yeah, the amount of fructose in fruit, good question. Probably not that much of a concern. Fruit has sugars. Fruit has all different types of sugars based on the type of fruit. That probably is not a problem. Is when fructose is added to all of the different types of either soft drinks, cookies, and all the rest, where the amount of it is significantly greater. And actually, I believe the composition of it is also very different. It's really fructose corn syrup is what it is. Corn syrup has been dropped and it's just called fructose, but it's actually fructose corn syrup that's put in.
I have a question. Obviously NASH is a ever increasing problem, and we've had delays in the therapies. But when it comes to the cost of pharmacologic interventions, the Institute for Clinical and Economic Review came out with a statement in July about it. They decided not to have their meetings because the FDA postponed the approval of OCA. Can you comment on Do you think insurance companies will ever put up the kind of obstacles we saw in the early days of hepatitis C fibrosis levels or lifestyle interventions they might even want to pay for prior to offering pharmacologic intervention?
Well, I think we saw similar discussions when statins first came out. You know, you had to have marked hyperlipidemia, you had to fail diet and exercise. And then what happened was people realized that a lot of patients needed it and they could lower their prices. Generics came out, and it was shown that these were life-saving. And so ultimately, we could either say that, well, the treatment is weight loss and anyone who can't achieve that is out of luck, or we could say that obesity is a very serious condition, and we're going to treat it just like we treat diabetes. Treating diabetes, type 2 diabetes, given all those TV ads, must be expensive now too, but we treat to avoid complications. So I think it will likely be restricted to those with moderate to advanced NASH. Mm-hmm. But for those patients, I suspect, one, the market will be big enough that the price will come down, and two, the cost benefit will be there.
Yeah, I would agree. I think in the beginning, most likely there will be a lot of barriers to get over to get the patients the medications like we had in hepatitis C. But as they're used and as they're shown to be effective and as the price will come down, it probably will be much more available. I agree it will likely be restricted to those with more advanced fibrosis. I'm sure there are going to be regional variations. You can't say that all insurance companies will cover it in the same way, and we'll probably have to figure out, like we did for the hepatitis C medications, which company, which drug, which insurance company, which drug. But I think as we look, further down the road, as Bob said, the prices will come down, generics will come out, it will be shown to be effective. There's been nothing ever in the US that has been effective in causing or leading to weight loss that's been used long-term and effective. And I don't think we're going to be pushing the burden of weight loss, diet, and exercise just to the patient. I still think we'll be able to, hopefully, be able to care for these patients with the therapies once they're out.
What do you have timelines that you could estimate for eventual approval of and the next pharmaceutical for NASH?
No.
I think most of us were surprised by the obeticholic acid thing. I think most of us anticipated it would be approved. And so I don't know whether this is going to be something where after 6 months, they're going to say, okay, or if they are going to require a new trial, in which case it'll be a couple years. So it's either 6 months or a couple years.
Question from the audience. Are there situations where you don't use a statin in liver disease?
Someone who's had a statin-related toxicity, but what happens, I think, is people only start statins when the liver tests are normal. They go up, they stop the statin, they come down, they believe they've done it, they've done something, they start them back on when they're down and they go up. What they're really seeing is the fluctuating liver function tests of NAFLD and thinking that they're causing something. So if you had just continued the statin, you would have seen those same fluctuations. If you look back at the original registration trial for Mevacor, the first statin, it had a placebo, and the incidence of abnormal liver function tests were higher in the placebo arm than in the statin arm. And so I think that if you just, measure CPK when you think you're having statin toxicity, and if you don't have an elevated CPK and you haven't gone up 3 to 4 times their baseline, just keep on and you won't see a problem.
And I also think what you'll see in patients who you start on statins, who start out with abnormal liver chemistries, many times on therapy, the chemistries will normalize because statins can as well treat some of the fatty liver. So you shouldn't be afraid by the abnormal liver tests.
Do your hospitals restrict the use of TPO agonists to just hematologists, or maybe you can comment further about availability?
I mean, these are mainly outpatient drugs. And so though the IV ones like Nplate tend to be used by the hematologist, most of the use of avatrombopag and lucitrombopag is by hepatologists. And I thought it would be hard to get, but I think because it's such a niche drug and it isn't used that much, it's actually relatively easy. It's getting the timing right with the interventionalists who are doing the procedures that's a challenge. You want to just shout your question from the back there and we'll repeat it? No, I can't hear you.
Actually,
So while we're waiting for that, I agree with Bob completely. The drugs are outpatient drugs. They're not restricted and they're pretty easy to get.
Yeah.
So we'll a lot of questions here. Let's see. Is there a safe level of alcohol in non-alcoholic liver disease? And how did the definition of 3 drinks per day being the cutoff, how did that come about?
Sure. Is there a safe level of alcohol in patients with NASH or fatty liver?
Or obesity?
Or obesity. Yeah. You know, the guidelines have actually just been pushed down, if you will. For people, safe would be 1 drink a day. I think the answer is going to be dependent upon the degree of liver injury. If there's significant fibrosis, cirrhosis, then it's going to be none or very little. If there is fat without any inflammation or fibrosis, I think you stick with the general guidelines, which would be 1 to 2 drinks per day for a man and 1 for a woman, 7 days a week. Where the initial 3 drinks a day came from historically, I don't know, quite frankly. It's based upon number of grams of alcohol that people take. So it depends if it's going to be whiskey or beer or wine or something else. But I can't answer the question as to where that came from.
Well, the last question is, if there is no indication of vitamin E without a biopsy,
Hi. There's a delay. I just wanted to sort of follow up on that question. So those original studies were done many years ago, and at a time point when NASH was really not nearly as prevalent. And obviously, it's like any study where they look at the volume of an inciting agent and look at a cutoff in terms of risk of developing liver damage. And so 3 drinks a day, that was it. Those studies have not been repeated in patients with pre-existing liver disease, and NASH would be considered a pre-existing liver disease. So I would think it would make sense that the amount of alcohol needed to further advance fibrosis in somebody with pre-existing liver disease would be much lower. I recommend to my patients, given the common sort of pathogenesis, pathophysiology of NAFLD and alcohol, that they eliminate alcohol from their diet. Anybody who wants to drink a drink a day, that's kind of an issue. A drink occasionally is probably fine, but I try to advise them not to take any consistent use of alcohol.
So one final question, is there an indication of using vitamin E without a biopsy?
Well, the recommendation is no, that you should have biopsy-proven NASH and be non-diabetic. Though I must say there have been cases where patients have clear evidence of moderate to severe liver disease, high enzyme activity, which to me indicates likely a lot of inflammation, in which I have used vitamin E because we have no other therapeutics. I think once we have an effective therapeutic, the answer will be no. but until then, I've used it in selected cases.
Welcome back, everyone. We're ready now for the next session. It'll be led off by Dr. Ira Jacobson on common dilemmas in the diagnosis and management of drug-induced liver injury. This session will be recorded lectures.
Hello, I'm Ira Jacobson from NYU Langone Health in New York City. I'd like to thank Dr. Lisa Petticone and the other organizers for the honor of joining the faculty of this year's GALA program. I also appreciate the opportunity to present my talk virtually with the hope and prayer that this is the last time it'll be necessary. In today's talk, I'll begin with some general comments about drug-induced liver injury, or DILI, which is a ubiquitous problem in clinical medicine, which we, as gastroenterologists and hepatologists, are frequently asked to evaluate and manage. In an exhaustive recent review published as the EASL Clinical Practice Guidelines on DILI in 2019, the traditional distinction is made between intrinsic and idiosyncratic hepatotoxicity. Intrinsic toxicity, often described as predictable, is dose-related and affects a relatively large proportion of exposed individuals. It usually occurs in a short time span and is reproducible in animal models. Acetaminophen is the classic example. Idiosyncratic injury is usually not dose-related, but interestingly does generally have a dose threshold of 50 to 100 milligrams per day. It occurs in a much smaller proportion of affected people and tends to have a variable but generally longer latency before onset. In 3 of the largest DILI registry studies, amoxicillin and clavulanic acid emerged on top in all 3, with tuberculosis drugs, especially isoniazid, in 2, nitrofurantoin in 2, and minocycline, diclofenac, and sulfamethoxazole, along with others, in 1 series each. Many herbal and dietary supplements, as shown here, have been implicated in DILI, but no list could be all-inclusive, and supplements should be considered as suspicious and warrant a search, such as on the NIH liver toxicity website, whether listed here or not. The bottom line is that great diligence is required to determine whether a patient with suspected DILI was taking an herbal product or supplement or exposed to any potential environmental toxins, such as hair dyes. The most common way we usually assess suspected DILI is by the hepatocellular, cholestatic, or mixed nature of the biochemical abnormalities with which the patient presents. Note that these categories are not mutually exclusive, especially when it comes to the mixed picture, where drugs like clavulanic acid and anabolic steroids can cause either a mixed picture or a purer cholestatic one. Although liver biopsies are not usually necessary, they're occasionally critical. We're going to give considerable attention to drug-induced autoimmune hepatitis today, but note also the drugs that can cause steatosis, including microvesicular steatosis, as opposed to the macrovesicular steatosis that we see so often in practice, as well as steatohepatitis, as we can see with drugs including amiodarone, tamoxifen, valproic acid, and methotrexate, along with other drugs associated with granulomatous hepatitis and nodular regenerative hyperplasia. In this slide, we distinguish between acute and chronic cholestatic liver injury, with emphasis on the potential for some forms of DILI to indeed cause chronic liver injury, including vanishing bile duct syndromes. As a general rule, cholestatic liver injury is a hallmark of many drug toxicities, and in the absence of another obvious cause, should always fuel a diligent search for an offending pharmacologic agent. The R value, a simple ratio of ALT to alkaline phosphatase, with each expressed as a multiple of the upper limit of their respective normal values, is a valuable tool for characterizing drug-induced liver injury. An R value of 5 or more indicates hepatocellular injury. A ratio of 2 or less on the right side shows cholestatic injury, and between 2 and 5 is considered a mixed picture of hepatocellular along with cholestatic injury. Hy Zimmerman was one of the great hepatologists in the United States in the 20th century and devoted most of his career to the study of drug-induced liver injury, about which he wrote extensively. At some point, he realized that the onset of jaundice in a patient with DILI is a poor prognostic sign. And he derived from that what came to be known as Hy's law, which is the idea that, as shown in the first row of this table, a bilirubin of more than 2.5 milligrams per deciliter combined with an ALT of more than 3 times normal, while the alk phos is less than twice normal, had a positive predictive value for mortality. And this wasn't just an idea, it was actually verified in clinical studies that followed, as well as his own experience, which led to this formulation in the first place. Recently, a panel of international experts proposed a new modified R ratio, but still calling it the new Hy's law in honor of the person who conceived all this, still keeping the bilirubin at a threshold of more than 2.5 milligrams per deciliter, but now substituting for the ALT and alkaline phosphatase stipulations the R ratio of more than 5, signifying hepatocellular injury, as we discussed a moment ago. And furthermore, it was proposed that if putting in the AST instead of the ALT yielded a higher R value, that should count instead. That is, the AST should be considered a parameter for the new Hy's law applying to a particular patient. And that yielded a positive predictive value for mortality of 14%. It's vital, of course, to exclude other causes of liver injury. And the ones I'd like to highlight here are hepatitis E, which is increasingly common and widely acknowledged now to be more widespread than we used to think, including many cases now seen in the United States. To look for hepatitis E, which you should do not only in suspected DILI, but in anybody with suspected acute viral hepatitis, you should get an IgM-HEV antibody. You should get an IgG antibody as well, because if it's negative, you might see a seroconversion a few weeks later that would also suggest that the patient was infected, particularly if you didn't get an IgM. And there is an available, but sometimes difficult to access, hepatitis E virus RNA test that you can get now. I recommend all three in cases of possible hepatitis E. And we also should get markers that we usually think of as associated with autoimmune hepatitis, since some drugs can cause an autoimmune hepatitis-like picture with important therapeutic implications. And we'll talk about that a little later. There have been associations between HLA types and some causes of drug-induced liver injury. Most clinicians probably have never done HLA testing in the evaluation of suspected DILI, and the second bullet under this table emphasizes that further validation of genetic testing is required before routine implementation in clinical practice. But, as also indicated in the comments on the slide, there may be selected clinical scenarios even now where genetic tests might assist in the diagnosis and management of patients. This would seem particularly true in instances of DILI, where the prevalence of an HLA type is very low in the general population and high with DILI, as with phenofibrate, shown in the middle of the table here, with a 43% prevalence rate in drug-induced DILI from this drug, as opposed to an only 1% prevalence of this HLA type in the general population. Now, the next two slides are taken from a reference with some beautiful pictures, as well as an excellent discussion of liver pathology in drug-induced liver injury. And I'd like to go through 4 examples, the first 2 being shown on this slide. On the left, we see a picture of a liver biopsy from a patient with acute hepatitis due to green tea. And the image shows ballooning with predominantly microvesicular fatty change, which we discussed earlier as an accompaniment of DILI in some cases, like this one, portal inflammation, and lobular and interface hepatitis. On the right side, we see 2 pictures from a patient with amiodarone-induced steatohepatitis, which is the hallmark of that particular DILI. And on the left side, we see frequent balloon cells with Mallory bodies, as shown by the arrow, whereas on the right side, we see sinusoidal and portal fibrosis with marked steatosis, and the arrow in this case shows an area of sinusoidal fibrosis. On the left side of this slide, we see a case of autoimmune-like hepatitis from nitrofurantoin. And what we observe on the biopsy is portal expansion due to dense lymphoplasmacytic infiltrates, shown here, with interface hepatitis and some lobular hepatitis as well. On the right side is a case of methotrexate hepatotoxicity, in which we see architectural alterations with a nodular focal appearance due to early cirrhosis, fatty changes, and portal inflammation. Liver biopsy is usually not necessary in suspected DILI, such as when there's an obvious culpable pharmacologic agent and the plan is simply to hold the drug and observe the patient, hopefully to spontaneous recovery. But the need for a biopsy may arise in either the acute or even chronic setting with a drug that's important for the patient's medical regimen, and there's uncertainty about the diagnosis of DILI or the extent of injury or fibrosis. From a practical point of view, the most common goal of liver biopsy in this setting is to distinguish DILI from autoimmune hepatitis, and in the process determine if the patient has a steroid-responsive histologic picture. Now, for most of the remainder of this talk, I want to focus on some of the more common causes of drug-induced liver injury and some aspects of clinical management that often arise in clinical practice in keeping with the assigned title of my talk. And the first I'd like to discuss is the most common DILI that you saw in those 3 registries earlier, that due to amoxicillin clavulanate liver toxicity. Clavulanate, not amoxicillin, has long been known to be the responsible agent for this entity, and it's thought to have an immunoallergic pathogenesis. The onset of injury can be up to 8 weeks after initiation and can also be over a month after discontinuation of the drug. And this occurs in about 1 in 2,500 prescriptions for this drug. It's more common in men, the elderly, or after repeated courses of the drug. It's usually a cholestatic picture, but it can be hepatocellular in its pattern in young adults and children in particular. And clinically, it's characterized by fatigue, low-grade fever, nausea, abdominal pain, pruritus, which I've underlined because it's been such a highlight and such a cause of misery for the number of patients I've seen with this over the years, and in some cases, jaundice. An illness can be quite prolonged, up to 24 weeks or perhaps even beyond. The management of this entity is supportive. You can offer antipruritic therapy. There are really no proven treatments from either randomized trials or any convincing case series. Urso and steroids have been used in case reports. The NIH liver toxicity website, and I quote here, says that the efficacy of steroids, which does come up as a question in the more severe cases in the minds of clinicians regularly, has not been demonstrated, and its use cannot be recommended routinely. And it's noteworthy that if you're familiar with this website, they often have illustrative cases, especially for the more common DILIs, and none of the 5 illustrative cases on the NIH liver tox website on this entity cite the use of steroids in any of the cases. But there are a few case reports suggesting improvement after steroids have been instituted. And I put what I found on the next slide, which shows 4 cases from a couple of different sources. With ages ranging from 20 to 81, as you can see. But the confounding factor is that all these patients got urso, while 2 of them got prednisone. The outcomes were favorable, as you can see, emphasizing the rapidity of resolution in at least one of the cases. You can see that where shown, the 3 patients for whom the bilirubin were given were intensely jaundiced. But these are very anecdotal case reports. The key to the management of clavulanate DILI, not to say that steroids should never be tried if in your clinical judgment you need to throw a Hail Mary, to use a popular phrase, is really time and reassurance, just marking off the days that can seem eternal to the patients until you know that resolution is going to occur. Although it should be noted that very rare cases of liver failure and the need for transplantation have been reported from this entity. The statins are a major issue in clinical hepatology and gastroenterology practice. There are, of course, 7 statins available in the United States. All 7 can be associated not infrequently with ALT elevations. We've all seen this. They're usually transient and asymptomatic. They may resolve spontaneously, although certainly in my experience, they sometimes don't resolve spontaneously. Lipophilic statins, as I'll show you in a moment which ones fall into that category, and lipophilic drugs in general are considered more likely to cause clinically significant liver injury. The most frequent reports of DILI have been with atorvastatin and statin and simvastatin, And this may be related not to an intrinsically greater risk of liver toxicity, but the frequency of prescribing at the time these reports were published. In one study, although less frequently prescribed, when incidence per person years was calculated, fluvastatin turned out to be the most commonly associated with statin-induced DILI. This slide divides the statins into those that are considered lipophilic and those that are relatively hydrophilic. And on the right side, we see those two, which are pravastatin and rosuvastatin. Even within the lipophilic category, there are some differences, perhaps notably that simvastatin is more lipophilic than atorvastatin. What about the seemingly relatively mild or modest ALT elevations up to 2 to 3 times normal that we see in clinical practice? Early animal toxicology studies in dogs showed ALT elevations without histologic damage. In humans, many authors have written that altered lipid composition of hepatocyte membranes is thought to result in leakage of enzymes after exposure to statins without true hepatocyte injury or any attendant risk of necroinflammation and progressive fibrosis. And this explains why ALT elevations up to 3 times the upper limit of normal are, quote, allowed in patients on statins. Indeed, no histopathology has been described in humans with this kind of transaminitis, as it's called in this branch of the statin-related literature. Now, hydrophilic statins, ironically, have been suggested in one fairly robust study that's referenced at the bottom to be more likely to cause these asymptomatic ALT elevations than the lipophilic statins, but I haven't seen that reproduced in other sources. And I don't know that this has really been a usable concept in my clinical practice. Toxicity, true liver toxicity with high doses in rabbits and guinea pigs have been tied to a reduction in mevalonic acid by the action of statins on HMG-CoA reductase or other steroidometabolites. And experimentally, this can be prevented by administration of mevalonic acid. The observations from 3 major DILI registries on statin-induced liver injury are shown in this slide. We'll focus on the Swedish registry because we'll discuss the other 2 in a moment. Of the 73 patients in the Swedish registry with 73 reported cases of statin-induced DILI, only 7 were actually graded highly probable by standard hepatotoxicity grading criteria. Most of the cases were associated with atorvastatin and simvastatin, but again, this may reflect frequency of use. A cholestatic or mixed pattern was more common with atorvastatin, but could be seen with both drugs. 2 patients had a dose increase within a few months before liver injury. And this is a question to always ask patients about in clinical practice when it arises. A higher daily dose was associated with an increased risk of DILI. Rechallenge with the same drug resulted in recurrent injury in 3 patients, 1 with simvastatin and 2 with atorvastatin. In light of the more encouraging anecdotal experience with use of another statin after DILI that I'll show you later, rechallenge with the same statin seems ill-advised in clinical practice. The 47 patients with statin DILI in the Spanish registry I just showed you on the previous slide are the focus here, where they were compared to a large number of patients with other causes of DILI. The statin group was significantly older and had a greater frequency of autoimmune findings, but most patients still did not have what appeared to be autoimmune disease. 8% of the patients had what appeared to be autoimmune-like findings. The distribution of hepatocellular versus cholestatic phenotype between the statin and non-statin patients was similar, but biochemically, the mean alkaline phosphatase was significantly greater above its upper limit of normal in the statin group. Dr. Mark Russo published this important paper on 22 patients with statin hepatotoxicity from the US DILI network. The median age was 60 and 68% of the patients were female. The pie chart shows that of the 22 patients, 12 had a hepatocellular pattern of injury, of whom 6 had autoimmune features. 9 patients were cholestatic, and there was 1 acute on chronic liver failure resulting in fatality. Liver biopsies showed a variety of findings, as shown. Statin hepatotoxicity in the DILI network was further evaluated by Dr. Russo and his associates into the latency periods, that is time of onset from the initiation of statin therapy. And it really breaks out remarkably evenly amongst these different gradations of intervals, such that about a quarter of the patients had started their statin within 3 months prior to the hepatotoxicity, and another quarter, to take the other extreme, longer than 12 months after the initiation of statins, with the longest case at 10 years. This has been quite relevant in my clinical practice, where I have seen patients with what seem to be statin-induced liver injury with quite long latency periods, in keeping with the concept embedded in this slide. Some patients in this analysis had autoimmune features. 6 of 12 had antinuclear smooth muscle antibody titers of more than 1 to 80 and or liver biopsy suggesting autoimmune hepatitis. They were more likely to develop chronic injury, and 2 of 6 received steroids, with 1 relapsing after stopping at 5 months of initial treatment. There's little literature on the outcome of rechallenge in patients with statin-induced DILI who were rechallenged with another statin. Bjornson reported the largest such series I could find in the literature, in which 3 patients were switched from atorvastatin to pravastatin or simvastatin, and 2 who had taken rosuvastatin and developed DILI were switched to either simvastatin or atorvastatin. In 2 other cases, one a patient in my practice with autoimmune-like hepatitis, shown at the bottom, atorvastatin was later switched to rosuvastatin with excellent results. It seems reasonable to switch from a lipophilic statin that has caused liver injury to a hydrophilic statin like pravastatin or rosuvastatin, but there's insufficient evidence to make firm recommendations. Very important dilemma that comes up in clinical practice is whether patients treated for DILI-induced autoimmune-like hepatitis can stop immunosuppressive therapy, or whether they need to be treated for quite a long time and then reassessed with liver biopsy, as is conventional with classic autoimmune hepatitis. This is a series from the Mayo Clinic in which 24 patients with drug-induced autoimmune hepatitis compared to 200 or so autoimmune hepatitis patients. And the main point is to show you that the patients in both groups had comparable serologic and biochemical findings, including autoantibodies and elevations in gamma globulins. Most of the patients in the Mayo Clinic series had DILI as a result of either nitrofurantoin or minocycline exposure, specifically in 22 of 24 cases. Although, as shown by the arrows on the left, jaundice and mean ALT levels were more common or higher with nitrofurantoin than with minocycline, no laboratory differences achieved statistical significance. This slide shows additional information from the Mayo Clinic series of 24 patients that brings a powerful message about the ability to discontinue immunosuppressive treatment in drug-induced autoimmune hepatitis. 14 of 24 patients discontinued treatment, with 0% relapse compared to 2 out of 3 or 65% in true autoimmune hepatitis patients. 9 patients with nitrofurantoin hepatitis discontinued after 6 had been treated for more than 12 months and 3 for less than 12 months. 5 patients with minocycline-induced hepatitis discontinued with where the treatment duration was known, 1 treated for more than 12 months and 2 for less than 12 months, which is a shorter period of time, as in the 3 patients here with nitrofurantoin hepatitis, than we would ever treat a classic autoimmune hepatitis patient. So drug-induced autoimmune hepatitis patients can be discontinued from therapy after appropriate remission for a couple of months, let's say, without undue fear of relapse. In yet another series of drug-induced autoimmune hepatitis cases induced by drugs from Professor Bjornson in Iceland, 11 of 15 cases were related to infliximab and 3 to nitrofurantoin. Latency periods range from several months in most infliximab cases and 1.5 to over 3 years for nitrofurantoin. 6 patients in this series had spontaneous improvement in liver tests, but 9 were treated with steroids at a median of a little over 2 months after elevated liver tests had been detected. ALT normalized after a mean of 154 days in all treated patients. Steroids were discontinued in all 9 with no relapses at a median follow-up of 4 years. And so the author concluded that it's not necessary to start azathioprine and that, as mentioned before with regard to the Mayo Clinic series, immunosuppressor treatment can be stopped with confidence after remission has been achieved for a suitable period of time with such therapy in these patients with drug-induced autoimmune hepatitis. It's notable that 8 of 11 infliximab patients in this series switched to adalimumab or etanercept with no liver injury reported. A few more points on TNF antagonists in DILI include the following. Cholestatic and hepatocellular patterns of injury have both been reported. The predominant form, however, is hepatocellular pattern with autoimmune features. Infliximab is the most commonly implicated, and that's after adjusting for frequency of use. Latency can range from 1 dose to 2 years or more, with a median of 13 weeks. And antinuclear antibodies, smooth muscle antibodies, elevated IgG, and various degrees of interface hepatitis on biopsy are common, as one would expect with drug-induced autoimmune hepatitis. Many reported cases have been treated successfully with steroids, and again, most patients have remained in remission when steroids have been discontinued, including some with relatively rapid tapers. There have, however, been a few reports of a second TNF antagonist re-challenge without recurrent DILI. With regard to amiodarone and liver toxicity, something that I've seen occasionally in my practice, of course, you all know how amiodarone is used for ventricular and atrial arrhythmias, particularly atrial fibrillation, and high loading doses are used compared to lower PO doses for maintenance doses. It accumulates in hepatocytes and other tissues and appears to result from damage to lipid bilayers and lysosome or mitochondrial dysfunction. Liver enzyme elevations occur in up to 50% on long-term therapy, and liver enzyme patterns are usually hepatocellular but can sometimes be cholestatic. Features on liver biopsy include steatosis, ballooning inflammation, later more intense inflammation, and eventually fibrosis. There are characteristic abnormalities on electron microscopy and bright livers on CTs without contrast due to iodinated drug accumulation, but neither of these findings, either on EM or CT, are specific for liver injury as opposed to drug exposure. IV administration with high doses can cause acute liver injury and even liver failure, but it's usually reversible. And long-term PO amiodarone therapy resolves slowly, but can result in cirrhosis by the time it's been recognized. Finally, liver injury from immune checkpoint inhibitors bears mentioning, and of course there are 2 major categories, the anti-PD-1s and the anti-CTLA-4s, which do have somewhat different risks of inducing immune-mediated hepatitis. The presentation is heterogeneous. Usually ALT elevations dominate, but they can be cholestatic. The usual onset is 1 to 3 months from the onset of treatment, and the picture can range from mild to fulminant. Autoantibodies are less common than in autoimmune hepatitis, prompting one author to say that this should be called immune-mediated hepatitis, not autoimmune hepatitis. And the histology is characterized by the features you see on the slide, which can include granulomas, including granulomas called fibrin ring granulomas, as well as bile duct injury, as well as necrosis. And the steroids are the mainstay of therapy, but not invariably necessary. A useful algorithm for immune checkpoint inhibitor DILI was presented by an international group of experts in a very fine review of DILI in Nature Reviews last year. If after evaluation ICI hepatotoxicity is suspected to be present, patients with ALT elevations of ALT to 3 times normal and bilirubin up to 1.5 milligrams can be cautiously observed. Patients with ALT between 3 to 5 times normal or bilirubin 1.5 to 3 milligrams should have their agent temporarily discontinued, and steroids should generally be used with a 4-week steroid taper when liver tests improve, with the subsequent addition of mycophenolate or increased steroid dosing if there's no improvement within 1 to 2 weeks. For ALT levels of more than 5 times normal or bilirubin more than 3, the ICI should be permanently discontinued and steroids initiated with the addition of mycophenolate quickly if improvement is not seen. A liver biopsy should be strongly considered if there's significant uncertainty about the cause of liver injury, particularly in the moderate or severe cases. I'd like to bring to your attention the previously mentioned vastly encyclopedic and very useful NIH liver toxicity website, which has a treasure trove of information. All you need to do is put the name of the drug into a browser, and type in the name of the drug, NIH liver tox, And you'll have a wealth of information at your fingertips with many references and illustrative cases in some instances. A few final points about DILI. First, the most common drug causing drug-induced liver injury is amoxicillin and clavulanic acid. The most common class of drug responsible for acute liver failure from DILI is antibiotics, actually, with isoniazid, sulfur antibiotics, and nitrofurantoin being the most common individual drugs. Remember that hepatitis E can masquerade as a drug-induced liver injury in 3 to 13% of cases. Drug-induced autoimmune-like hepatitis responds to steroids and generally doesn't recur after a steroid taper. The addition of azathioprine may not be necessary. Drug-induced liver injury with predominant elevations in ALT and AST levels, in other words, a hepatocellular pattern, in those who develop jaundice has a mortality of approximately 10%. Hy's law, or the new Hy's law, as I explained it. And finally, N-acetylcysteine should be considered for patients with non-acetaminophen drug-induced liver failure. Of course, it's been a standard for acetaminophen DILI for a long time because it's been shown to improve transplant-free mortality in a randomized controlled trial. I'd like to thank you for your attention today. Hello.
Okay, hello everyone. Thank you for inviting me to give a talk in this GALA Tri-State conference. I'm going to be talking to you guys about the management of fecal incontinence. And my name is Baha Moshiree, and I'm the Director of Motility at Atrium Health. The patient case is a 42-year-old who has left-sided ulcerative colitis that was diagnosed in 2001. They're seeing us for fecal incontinence and constipation. Prior medications have been a bunch of different medications, including a lot of immunomodulators, methotrexate, oral mesalamines, and steroids. And this patient is actually currently in remission from her ulcerative colitis and has had a colonoscopy in March of 2020 that showed complete resolution. The symptoms are occurring during flares of her UC. The symptoms specifically during those flares are diarrhea and tenesmus, with this bloody bowel movement and urgency, and the patient's evacuating 3 to 7 times a day. When the patient's constipated, they feel they have rectal pain, incomplete defecation, straining, pencil-thin stools, and then no bowel movement for 3 days. So this patient goes from being in flares to having these episodes of constipation. During those episodes of constipation, patient also states that they're unaware when they soil their underwear. She's been taking Marilax for her constipation. And she also has a history of endometriosis with an XLAP in the past for that, obesity, and history of elevated LFTs. Has had C-section ×3, robotic, a hysterectomy, bilateral sublingual and then an external hemorrhoid surgery as well. She takes hydroxycodone for pain in the rectum, and then linaclotide at the 145 microgram dose, and then Marilax as needed, dicyclamine for pain, and then clonazepam. And then again, we discussed her ulcerative colitis meds already. So what are our patients' risk factors for fecal incontinence? So, we look at the anatomy of the rectum, the nerves in the rectum, and then the central nervous system, the spinal cord, and the autonomic nervous system. So for anal sphincter muscle issues, the risk factor our patient has is that she has had a hemorrhoidectomy. The other risk factors are obstetric surgery, some history of dilation, neuropathy, and then the mechanistic effect is a sphincter weakness and loss of the sampling reflex in the rectum. There's also, as far as rectal risk factors, smoking can cause impairments, rectal seal, obesity, IBD, and IBS would be the risk factors in our specific patient here in this scenario. And then there's loss of accommodation and loss of sensation and hypersensitivity, which are results of that. Pudendal nerve injuries can cause sphincter weakness, sensory loss, and impaired reflexes. And these are from things like obstetric surgery, surgical injuries such as hysterectomy, excess straining, which our patient has both of these, perineal descent, and then rectal prolapse. And then CNS and autonomic nervous system issues are things like diabetes, spinal cord injury, head injury, back injury. And these can cause loss of sensation, impaired reflexes, and then secondary myopathy or loss of accommodation. So what is the pathophysiology of fecal incontinence? We can have structural abnormalities, as we discussed, with, for example, this patient getting a hysterectomy and a hemorrhoidectomy. There are stool characteristics that are important, like the consistency of the stool. And then there are functional abnormalities that are also important, such as the coordination of the muscles and how weak or not weak the muscles actually may be. We know that the prevalence of fecal incontinence is really high. A study that was conducted by Daita et al. Used data from the National Health and Nutrition Examination Survey, and this was over 52,000 patients. And when they looked at the prevalence of fecal incontinence, it was 9% in this survey that was done in 2010. And fecal incontinence occurred at least weekly in 1% of the participants, and it was similar in women. And then surprisingly in men, it was like 7.4% in men. And amongst individuals that are 70 and up, the prevalence is actually almost 18%. What are pelvic floor disorders? So pelvic floor disorders also are common in men and women. These are things like pelvic dyssynergia, pelvic organ prolapse, things such as rectoceles and cystoceles that post-pregnancy especially can cause problems, anorectal pain, such as proctalgia fugax and levator ani syndrome. Anal fissures can be an issue, hemorrhoids, urinary and fecal incontinence are what we're discussing here, but they are part of the pelvic floor disorders. And then these pelvic pain syndromes that are really important in our patients as we address all of their symptoms, including pain as well as their fecal incontinence and constipation. So the prevalence of pelvic floor disorders is also common. Urinary and fecal incontinence often go together. In 30% of women who have urinary incontinence, they will also have fecal incontinence. And then 1 in every 9 women will undergo some surgery for a pelvic floor disorder, and 24% of women at least have one pelvic floor disorder. So again, these are very common. In nursing homes, 60% of nursing home residents have loss of bowel control and or urinary incontinence. And dyssynergic defecation itself, which is an abnormal coordination of the muscles in the rectum, is found in both irritable bowel syndrome and then also inflammatory bowel syndrome, which our patient suffers from. In IBS, it's been rated to be between 20 to 80%. And then in patients who have IBD, it's between 45 to 97%. In those patients without an ileal pouch anal anastomosis, and then in those who have an ileal pouch anal anastomosis, it can be 25 to 75%. So in every patient, we'd like to determine what are the clinical subtypes of fecal incontinence. So there's passive incontinence. That's when the patient is unaware of the passage of stools, and usually that's due to a disrupted internal anal sphincter. There's also urge incontinence. That's release of feces despite awareness. So this time the patient knows that they're going to release feces and they try to retain it, but they are unable to. And that's usually due to an external anal sphincter dysfunction. And then there's fecal seepage. So fecal seepage, such as what our patient is experiencing along with her urge incontinence, is when there's small amounts of fecal material on the undergarments and the patient is unaware of it. And this is usually due to impairment in actual rectal sensation. So what's very important for our patients that we see in the motility lab and patients who have fecal incontinence and constipation is a digital rectal exam. So Satish Rao would be very proud that we have presented that the sensitivity of the digital rectal exam is 75% with a specificity of 87%. And then the positive predictive value, when done well, is 61%, and the negative predictive value is about 91%. So this is a diagnostic test in itself. Of course, it has to be done correctly. Now, again, the rectal exam can help identify all of the following. So external inspection tells us if there's a rash, if there's some excoriation, hemorrhoids, fissures, a fistula. These are all things that would be concerning in a patient that has ulcerative colitis especially. We can look at the anal wink, which is the anal cutaneous reflex, see if there's nerve damage, for example, that may be impaired. What is the perineal descent? Is there rectal prolapse? Although I would say the way we position patients, we may not always feel the rectal prolapse, and that may be better evaluated when patients in stirrups. We can see if there's a rectal seal by palpation. We can see if there's masses. We can evaluate the tone of the both during strain and also during just relaxation. and see what that is about. And then if there's stool present, we can see the texture or feel the texture of the stool that's present there. Our patient's rectal exam is this. So her external anal exam, she had external hemorrhoids. None of them were thrombosed, no fissures, no fistulae, no excoriations or rashes. She did have an anal-cutaneous reflex that was present. She had appropriate rectal descent. Rectal vaginal prolapse was not felt. And then she did have a weakened resting tone and squeeze pressures just on palpation that was felt. And then we did not feel that her abdominal muscles were contracting to push things forward. She was not able to expel the finger during straining, and we did feel a small anterior rectal seal, and no stool was felt in the rectal vault. So again, we have the physiology of defecation, which is very intricate. So in figure A here, on the left, we're looking at just during rest. What does the pelvic floor normally do during rest? So there's a complex sequence of events that's going to happen when the patient goes from rest to straining. So there's a progressive rectal distension that leads to relaxation of the internal anal sphincter that occurs. There is an urge to defecate, and that increases as the stool enters the rectum from the sigmoid colon. When defecation is desired, then the anal-rectal angle is actually straightened to facilitate the patient having a bowel movement. Abdominal pressure should then increase when the patient's straining, and this results in descent of the pelvic floor, the contraction of the rectum, and then inhibition of the external anal sphincter where it should relax. And thereby, we should be able to then evacuate the rectal contents. For continence to be present, it depends also on a number of factors. And those include the stool volume, the consistency, the patient's cognitive abilities and capabilities, rectal distensibility, whether the patient can sense it, sphincter function, and then the anal-rectal reflexes that may or may not be present. Barriers that help preserve continence are the rectum, the internal external sphincter, and then also the puborectalis muscle that you can see on this figure in B goes around and binds the pubic symphysis and goes around the rectum. This muscle relaxes when the patient strains. All of these have to be present for us to be able to defecate. The diagnostic testing that is available for evaluation of fecal incontinence, for example, and constipation are anorectal manometry. This quantifies sphincter pressure, sensation, compliance, as we talked about. It has good evidence. Endoanal ultrasound specifically for fecal incontinence is important as it assesses the internal anal sphincter, whether there's a defect or not, the external anal sphincter thickness, and the integrity, and there is also good evidence behind that. And then there's needle EMG, which can distinguish between neuropathy and myopathy. There's fair recommendation and evidence for that. And then surface EMG provides some information on whether the sphincter tone is weak or normal. However, I feel that we have good testing, at least with the exclusion of biofeedback therapy, to figure out if the sphincter muscles are weak. Talk about the London classification here, which really tries to standardize how anorectal manometries are performed, as they have been done with different standards and different ways that we have interpreted these studies, depending on the equipment and where these procedures are done. Different normal numbers are used. And really, this protocol is very similar to the Chicago classification for esophageal disorders. And the way to do the anorectal manometry is you have to wait for a 3-minute stabilization based on the London protocol. The rest phase is about 60 seconds after the stabilization phase. The short squeezes are each 5 seconds, with the long squeeze that lasts about 30 seconds. We also evaluate the cough reflex in patients, especially with fecal incontinence, to see if the rectal pressures appropriately increase with coughs. And then during the push maneuvers, which are done 15 seconds each, we evaluate whether there's normal relaxation of the anal sphincter muscles and the puborectalis muscle with defecation. And then lastly, the rectal anal inhibitory reflex is measured, and that's with balloon distension in the rectum, where we see if the internal anal sphincter actually relaxes, which is a normal mechanism. So based on these findings, we look at the rest and squeeze pressure, and this is the abnormality we found in our patient. And this goes through all the different versions of the findings on this algorithm. So if the anal rest pressure is over the upper limit of normal, then the patient may have anal hypersensitivity. Our patient in our scenario did. If the patient's rest pressure is lower than the lower limit of normal, and the squeeze is also in the lower limit of normal, then there's a combined hypotension and hypocontractility. Our patient also had this. If the squeeze pressure is in the lower limit of normal, is not in the lower limit of normal, but the anal rest pressure is, then there's anal hypotension with normal contractility. And then if the anal squeeze pressure is in the lower limit of normal, then there may be anal hypocontractility, but the anal rest pressure is normal tensive. And then if none of these exist, so there's normal resting pressure, normal squeeze pressure, then there's no disorder of tone or contractility. So again, the London classification parameters are 4. There are 4 distinct parameters: disorders of rectal anal inhibitory reflex, which is the rare. There's also disorders of anal tone and contractility, which looks at the anal resting tone and squeeze pressures. Rectal anal coordination is very important. This is how we diagnose if the patient has what we call dysenergic defecation, where the rectal pressure should increase and anal pressure should decrease with push maneuvers. And then rectal sensation testing, 2 out of 3 have to be abnormal for us to call that abnormal. So our patient's anorectal manometry is here. There's weakness of the external sphincter muscle that's found. We have the rest pressures that are evaluated here. Then we go to squeeze pressures and then the sustained squeeze. We usually want the squeeze pressure to double from what rest pressure is, which does happen in this patient. But if you can see the pressures here on this color topography tend to decrease with time. So the patient was not able to hold the squeeze for 30 seconds. Also during push, there was an abnormal propulsive force, meaning the patient was not using their abdominal muscles and rectal pressures did not increase, but the sphincter muscles did relax. And in a normal phase, for example, the sphincter pressures at rest should look very similar to this. And so this patient also had rectal hypersensitivity, where the maximal tolerable volume this patient could do was 80 mils. Usually patients can tolerate up to at least 200. The patient had blunted urge to defecation, but had normal sensation. And then during the balloon expulsion testing, where a balloon is filled with 50 mils, the patient was not able to expel this balloon, mostly due to weakness. So how useful is anorectal manometry for evaluation of fecal incontinence? Diagnosis can be confirmed in 95% of patients, and it provides new information for 98% of our patients. And it can influence the treatment because it depends on where the defect may be in each of the patients. So this is just an example of one of our patients who has fecal incontinence and who we performed the endoflip procedure. This is done for esophageal diseases, for example, to rule out eclasia during endoscopy. And when done for rectal pressure measurements, in this patient, the rest pressure and what we call the distensibility index and the diameter was high, and the pressures were actually very weak. And then with 50 mils during squeeze pressures, this patient had the same findings, where the squeeze pressures were actually low and the distensibility index was high. Endoanal ultrasound has also been performed, and this looks at the internal anal sphincter, for example, and the external anal sphincter, and you can really see if there's a defect in any of those muscle groups, for example, from hemorrhoidectomy or prior surgery or dilations. So a summary of the testing that we have, we didn't really talk about MRI defecography or pelvic defecography. For functional assessment of the rectum, anorectal manometry has good evidence. For anatomic assessment, ultrasound has good evidence. Defecography and MRI may not be as helpful in a patient with fecal incontinence. There's fair evidence. Surface EMG has fair evidence. And then pudendal nerve, more latency testing that we didn't talk about, has poor evidence. And this is to assess the function of the sacral nerves and the innervation of the external anal sphincter. And then flip technology is really a new technology that's yet to be determined and standardized in the future. So now we are at the management of fecal incontinence, which is really the crust of what we wanted to talk about. So there are dietary, lifestyle, and medical treatments that are available for evaluating fecal incontinence. And fiber therapy comes up the most often, right? So there has been studies by many groups on the importance of fiber therapy for treatment of fecal incontinence. This study had 39 patients, and they looked at in 3 groups. The first group was on their usual diet and 25 grams of Metamucil. The second group was on their usual diet and gum Arabic. And then the third group of patients was on pectin, which was really the placebo group. And when you look at the patients that got Metamucil, the amount of soft formed stools was higher, and there was less of these liquid bowel movements when you looked at the percentage of stools. So fiber therapy can help with continence. And biofeedback therapy is probably one of the second most common things that we refer our patients to who have either sphincter weakness or who have fecal incontinence, whether it's due to decreased propulsive force, for example, like in our patient. And what biofeedback does, it helps coordinate treatment. The therapist has to be trained very well for this. Physical therapists and nurses have done this procedure. And this is where we train the patient to coordinate the contractions of the pelvic floor muscles. We do strength training where we do anal canal pressure feedback, and the patient is able to see what they're doing in order to improve their symptoms. And then rectal sensation, we're able to improve rectal sensation by doing a computer-inflated balloon testing. So the process is that the patient really visualizes what they're doing. They have electrodes that are placed in the rectum, and they're able to really see these signals on a display on a computer and really be able to see and feed back to the brain what is happening and what they need to do in order to improve rectal function. This is just an example of one of those biofeedback, what the output is, and patients are able to see their abdominal musculature as there's contractions, and then they'll see an increase in the contraction amplitude and how long they're able to hold it. And with sessions, usually about 6 per patient, some patients can do it in 4, we can see improvements in these muscle contractions. And when we compare biofeedback therapy and pelvic floor exercises versus just pelvic floor exercise and fecal incontinence, the studies have shown that the fecal incontinence severity index has improved in those patients who have had biofeedback. So biofeedback therapy is very important, and this is obviously a small study. There have been many larger studies that have shown improvement in fecal incontinence with use of biofeedback. So in this study, the different groups have had different improvements in their fecal incontinence. The blue here is the patients on biofeedback therapy, and the red is the patients that have had no treatment. And when you look at the patients with biofeedback therapy, there, of course, is much more common. Group A has continence fully recovered, and the biofeedback group shines here. And then Group B has had over 75% reduction in the percent and the number of incontinence episodes. So at about 60 months, so these are long-term results in the study, 86% of those that were treated with biofeedback therapy were fully continent or had over 75% reduction in their incontinence episodes. So how about pharmacologic agents? What do we have as far as therapies other than, of course, we talked about fiber, which has been shown to improve symptoms. So supportive care is usually with diet. If patients drinking a lot of coffee, we try to limit that because that can cause diarrhea and fecal incontinence. Alcohol intake, fructose, lactose, a lot of these sugars can cause things like increased osmotic activity in the small intestine, and so these can be a problem. These are also limited in the low FODMAP diet that we give IBS patients, and IBS, of course, is a risk factor for fecal incontinence. Antibiotics, obviously, in our patient, she was on laxatives. She had taken Miralax and linaclotide. Things like metformin can cause diarrhea. This patient is also on narcotics, which can cause impairments in rectal sensation, which our patient does have. And then there are other drugs that alter sphincter tone, such as nitrates, narcotics, of course, calcium channel blocker, and even sildenafil. And then medical therapies, we talked about psyllium. It's beneficial for low volume stools, but in some patients with fecal incontinence, it can exacerbate symptoms and decrease rectal compliance. in those who have diarrhea, you want to really treat the underlying etiology. Maybe they're lactose intolerant. Things like loperamide can be effective. And then if there's fecal impaction, use of enemas may be important because maybe the patient has megarectum and has impaired sensation. And then for rescue, we do suppositories or enemas acutely to see if this can help prevent these episodes of fecal incontinence if it's due to rectal distension and fecal retention. So the other pharmacologic agents, the antidiarrheals, the tricyclics, and bile acid resins, none of these have been evaluated in large randomized controlled trials in patients who have fecal incontinence. So these are all going to be small studies that we'll talk about here. Loperamide. So in this study, they investigated the effect of loperamide at 4 milligrams 3 times a day on continence to a standard volume of rectally infused saline. So these patients had rectally infused saline, and they had anorectal manometry in 26 of the patients who complained of chronic diarrhea. And here we looked at the effects of loperamide on improving the stool weight, so that decreased. The number of bowel movements also went down a week, and then more of the stools were formed. And all of this was statistically significant. And then more importantly, urgency also improved. So the stool consistency, if you look at day 6 on loperamide treatment, this is only in 11 patients, improved over placebo. And then when they did the saline continence test in these 11 patients, loperamide did improve continence as well. Tricyclic antidepressants have also been studied in idiopathic fecal incontinence. This is in 18 patients, 24 controls that were compared in this study. And amitriptyline 20 milligrams a day for 4 weeks was effective in 89% of the patients who reported improvement in continence. And this is comparing the baseline versus end of treatment. There was a reduction in the frequency and the amplitude of the rectal motor complexes. And then there was also a reduction in anal pressure. We also have bulking agents. So the bulking agents are the formal name for this is called Celesta. This is a non-animal stabilized hyaluronic acid dextronomer. And randomized controlled trials of over 200 patients that use this versus placebo have found that 50% of patients had significant improvement in fecal incontinence episodes after getting these injected above the dentate line. So usually when we inject it, we do 4 injections of 1 ml into the deep mucosa, and it's about 5 millimeters above the dentate line. And if this response is adequate, it can be done again if the patient has response and then has recurrence of symptoms again. So it can always be done a second time. And it's usually done for passive fecal incontinence, such as what our patient actually does have. The complications with this procedure can be rectal pain, hemorrhage, and then development of abscess. And 3-year follow-up has shown that there is improvement in fecal incontinence episodes and quality of life up to 36 months. So this is looking at the number of fecal incontinence-free days with this dextronomer microsphere injection, and you can see that it lasts up to 12 months in terms of improvement in fecal incontinence, and there's almost a 2-fold increase of incontinence-free days, which is an improvement for patients. I mean, if their fecal incontinence goes down by half, that's an amazing amount of improvement for most of our patients. Surgical management, there are many surgeries that are available. I would say that colostomy, many of these we don't normally do, often sphincteroplasty. The most common procedure is sacral nerve stimulation, which is what I'm going to concentrate on, and this increases stool consistency, sphincter tone. Side effects are infection, and then it is, there could be like lead migration, but it is a safe procedure, especially when compared to the others. This is a system that's available. It has a lead that's placed next to the sacral nerves, and there's also a temporary version of this that can be implanted first to see if there is improvement in patients' fecal incontinence prior to having it permanently placed. And usually it's urologists and colorectal surgeons that place these. So with the sacral nerve stimulation system, bowel control has improved. This is looking at improvement in weekly incontinence episodes over time, and it's up to 36 months. And 40% of the patients had 100% improvement, 36% had 75 to 100% improvement. So the sacral nerve stimulator is very effective, and just based on my own experience, we refer a lot of patients for this procedure and have great benefits. So lastly, this is our last slide here. The promising future therapies are translumbular neuromodulator therapy for fecal incontinence from Satish Rao's group. And this is like a magnetic neurostimulator that patients have that really is at different hertzes. So they looked at patients who had fecal incontinence and the percent response in each 3 groups that had fecal incontinence. So there was 11 patients in the study. With the 1 hertz, it was the most effective. 90% had improvement in their fecal incontinence episodes. With the 5 and 15 hertz, they were not as effective as the 1 hertz. So this may be a promising new treatment that's available for our patients, in addition to the sacral nerve stimulator. All right, thank you.
Hello, everyone. My name is William Chey. I'm a professor of gastroenterology and nutrition sciences at the University of Michigan in Ann Arbor. And I'm going to talk to you today about microbiome-based treatments for the irritable bowel syndrome, or IBS, bugs or drugs. This is my disclosure slide. And I think it's valuable to start off with a discussion of definitions, microbiota versus microbiome. The microbiota refers to the overall community of microorganisms living within your GI tract. The microbiome, on the other hand, refers to the collective genomes of those microorganisms. So microbiota, organisms, microbiome, the genomes. Now, the microbiota and microbiome have a profound influence on normal development and function of the gastrointestinal tract. It plays a role in immune activation, permeability, secretory function, visceral sensation, as well as motility. So the microbiome is critically important to the health and development of disease in regards to gastrointestinal disorders. There are a plethora of different factors that can influence the composition of one's microbiota. How you're born. For example, vaginal delivery and cesarean section leads to different characteristics of the microbiome. Genetics, your environment, i.e. your diet and how clean of an environment you live in. Your level of physical activity, psychological distress, medications, as well as whether you smoke or drink, all these things can influence your microbiota. An age-old question has been, is there greater influence on the microbiome from genetics or environment? And we got at least a partial answer to that by a very important paper that was published in Nature now more than a year ago, which actually came to the realization that environment plays a significantly greater role in shaping the microbiome than does genetics. And they did this by looking at the microbiome from individuals who were very similar genetically, i.e. twins, who were living apart, versus those individuals that were not genetically similar, but living together. And what they found was that the people that had very different genetics, but were living together, actually had more similarity in their microbiome than people that were genetically very similar twins living apart. We're going to focus the rest of our discussion on the irritable bowel syndrome, or IBS. And remember that IBS, according to the Rome 4 criteria, is a symptom-based diagnosis relying upon the presence of recurrent bouts of abdominal pain in association with altered bowel habits. And that altered bowel habits can be either diarrhea, constipation, or a mixture of diarrhea and constipation. The current thought in regards to the pathophysiology of IBS is that it's heterogeneous. There are probably multiple factors which interplay to different degrees in individuals leading to the symptoms of IBS, abdominal pain and altered bowel habits. It's becoming increasingly clear that what's happening in the luminal environment, the luminal microenvironment of the GI tract, is critically important in regards to influencing the function of the enteric nervous system, which communicates with the brain in our heads, as well as the gut immune system. And it does so via the epithelial cells that line the gastrointestinal tract. So although we've made fun of for years of patients talking about leaky gut, it turns out that intestinal permeability likely does play a critically important role in terms of separating what's going on in the luminal microenvironment from those nerves and immune cells in the wall of the intestine and colon. We also know that there are intrinsic differences in the microbiome between patients with IBS versus healthy controls. In fact, a recent meta-analysis published in Gastroenterology actually amalgamated data from 24 studies conducted in 22 different manuscripts published in the medical literature. And they found that while there were differences from study to study, a consistent message was that the microbiome from patients with IBS differed from healthy controls. Some of the more durable themes, recognizing that none of these things are universal themes, but some of the more durable themes were that IBS patients had lower concentrations of bifidobacterium and fecal bacterium and higher concentrations of Lactobacilliaceae, Bacteroides, and Enterobacteriaceae. We also know that there are a number of lines of observation and science that link the microbiome or microbiota to IBS. First is this concept of post-infection irritable bowel syndrome, this notion that while the vast majority of people that experience an acute gastroenteritis, traveler's diarrhea, food poisoning, completely recover with no consequences, there's a small percentage, maybe on the order of 7 to 15%, who will go on to develop more long-lasting symptoms compatible with the diagnosis of IBS. And that's what we refer to now as post-infection IBS. By the way, the correct terminology is post-infection IBS, not post-infectious IBS. Also, we know that children exposed to multiple courses of antibiotics are more likely to go on to develop irritable bowel syndrome later in life than kids that don't receive antibiotics. And finally, we also know that a whole range of microbiome-based therapies, whether you're talking about diet, probiotics, antibiotics, can offer benefits to subsets of patients with IBS. Again, drawing that possibility that manipulating the microbiota may in some way impart benefit to at least a subset of IBS patients. We're going to next turn our attention and really spend the rest of our time focusing on treatment options that involve the microbiome in patients with IBS. And I like to use a garden motif as I think about the different options that can affect the microbiome. First is fertilizer, so prebiotics in food. Then there's seed, so thinking about probiotics and fecal microbial transplant in that category. And then finally, weed killer, and that would be antibiotics. And you need all of those different things in different proportions to really get the most beautiful garden, as depicted at a picture of Mathai Gardens from the University of Michigan. So let's start off with diet. And we're going to talk about a variety of these different interventions, but we're going to start with diet. People may not necessarily think about diet as a microbiome-based strategy, but it is, and I'll show you data for that in a second. But realize that right now, the most evidence-based diet therapy for patients with IBS is the low FODMAP diet. There are actually multiple randomized controlled trials. We summarized data from 7 randomized controlled trials in this meta-analysis that we recently published in the Red Journal, which showed that in aggregate, the low FODMAP diet was more likely than a number of different comparators to provide benefit to overall symptoms in patients with IBS. Now, in fairness, you'd have to say that there was significant heterogeneity from trial to trial, a whole bunch of different comparators. These studies were not blinded, different durations, different numbers, all relatively small numbers of patients. So bottom line here is there was a high risk of bias. So this is by no means a perfect data set, but the data that we have fairly consistently suggests benefit for a subset of patients with IBS. Now, right now, we're still in an era where we empirically choose a diet or a medication, for that matter, based on a patient's symptoms. But really where we want to go is more towards a precision medicine, or in this case, a precision nutrition model. Precision nutrition is defined as it suggests that it's possible to have sufficient quantitative understanding about the complex relationships between an individual, his or her food consumption, and his or her clinical phenotype, including health, to offer nutritional intervention or advice, which is known to be individually beneficial. So how close are we at the current time to a precision nutrition model? Well, we're still a long ways away, but we do have some glimmers that suggest that we might be able to develop strategies or biomarkers that would allow us to go down this precision nutrition pathway. For example, there are now multiple studies, 3, 4, 5 studies, showing that characteristics of the microbiome, the stool microbiome, before a person goes on a diet intervention can predict whether they're likely or not likely to respond to a dietary intervention like the low FODMAP diet. This is data from Norway showing just that characteristics of a patient's stool microbiome before they go on a diet intervention identifies patients who are more likely to respond to the low FODMAP diet. There's also data suggesting that metabolomics, in other words, looking at the metabolic byproducts that are arising from the activity of the microbiota in the GI tract, can also offer insights into whether a patient is less or more likely to respond to the low FODMAP diet, or for that matter, in this case, as this study shows, also a probiotic supplement. So in this study, investigators from King's College actually looked at volatile organic compound profiles from gases emitted from stool collected from IBS patients before they were either treated with the low FODMAP diet or a probiotic supplement. And this is what they found. They actually found that characteristics of the VOC patterns almost perfectly predicted the patients who were responders to the low FODMAP diet or a probiotic supplement. I mention that because this strategy may, if it turns out that this is validated by other groups, may be applicable broadly to microbiome-based strategies. Let's next talk about pre-probiotics and postbiotics. So realize there are many studies which have evaluated the potential benefits of probiotic supplements in patients with IBS. In fact, in this systematic review meta-analysis that was part of the American College of Gastroenterology evidence-based monograph on treatment of IBS, they identified 53 randomized controlled trials with over 5,500 patients enrolled in these trials. And overall, there was a small but statistically significant benefit offered by probiotics in terms of improving global IBS symptoms, abdominal pain, bloating, and flatulence scores. Unfortunately, what was also found, though, was that the evidence was not strong enough to be able to make specific recommendations regarding specific probiotic supplements. So while this document said we suggest probiotics taken as a group to improve global symptoms, as well as bloating and flatulence in IBS patients, it also was very clear to say that they could not recommend, that we could not recommend specific probiotic supplements for patients with IBS. And the AGA, in their document that was just recently published, actually went a step further and said that probiotics should only be used in IBS patients as part of a clinical trial. That right now, the evidence really does not match the enthusiasm that patients have for probiotics as a treatment of IBS. Also realize that probiotics may offer benefits for cognitive emotional function. So-called psychobiotics have been evaluated now in a wide range of different trials in healthy volunteers. And in this meta-analysis that was just recently published, it was actually found that psychobiotics were more likely than placebo to lead to improvements in depression, anxiety, and stress in otherwise healthy individuals. And we now also have a study from IBS patients that suggests that a psychobiotic, Bifidobacterium longum, NCC 3001, was more likely than placebo to lead to improvements in mild depression in IBS patients. And that was associated with measurable changes in the amygdala and other parts of the brain involved with cognitive emotional function measured by functional MRI scanning. However, there are a number of points to ponder. Again, the ACG, evidence-based treatment monograph, and the AGA guidance on probiotics have both been pretty conservative in terms of recommending the use of probiotics in patients with IBS. And I must say that I agree with those recommendations. Realize that the current quality of evidence is really low. That the empiric therapy paradigm, this idea that one size fits all, you give this probiotic to all the patients with this symptom-based condition, probably doesn't even make a lot of sense based upon all that I've told you in regards to the heterogeneity around the microbiota and the metabolome that occurs as a consequence of the microbiota. Also, remember that probiotics are regulated as food supplements. So bottom line here, buyer beware. Switching gears a little bit, but on the same theme, realize that there's growing interest in providing prebiotics instead of probiotics as a treatment for IBS. So this is one study that was recently published by a group in Spain that looked at the low FODMAP diet versus a prebiotic and a modified Mediterranean diet in a relatively small number of IBS patients, and found that while both improved symptoms compared to baseline, there was no difference in the magnitude of benefit between the two interventions. Now, the paper concluded that this was a consequence of the prebiotic supplement, but another question that one might ask is whether or not the Mediterranean diet offers potential benefit for patients with IBS. Time will tell. We need more data on that particular point. All right, let's next shift focus to antibiotics and just review the data suggesting that rifaximin provides benefits for global improvement in IBS symptoms. This is data from a meta-analysis we published a number of years ago now. At that time, even in 2012, there were 5 randomized controlled trials, all suggesting benefits for global IBS symptoms in patients using rifaximin versus placebo. The Target 3 study is the most recent randomized controlled trial, a very large study, over 2,400 patients who all received an open label course of rifaximin. And by the way, the response rate was 44%, exactly the same as the response rate that we reported in that meta-analysis I told you about a moment ago. Of those individuals that responded, about 2/3, or roughly 60%, experienced a recurrence in their symptoms during the follow-up period. And those patients were re-randomized to either a second and third course of rifaximin or placebo. And bottom line here is that the second and third courses of rifaximin, again, led to small but statistically significant benefits in terms of improving overall IBS symptoms compared to placebo. And that's why the current FDA approval is for 550 milligrams 3 times a day for 14 days, up to 3 courses of therapy. Now, a really important question here, and particularly in light of the response to rifaximin, is whether patients that get better from rifaximin are suffering from SIBO or whether they're suffering from IBS. In other words, it may very well be that SIBO simply leads to symptoms that otherwise look just like IBS, but it might also be that patients with IBS related to their underlying abnormalities in motor function, immune function, permeability, might be predisposed to developing SIBO. So what's the chicken and what's the egg still remains to be determined. What I think is pretty irrefutable at this point, though, is the relationship between bacterial contamination of the small bowel and a higher likelihood of patients reporting IBS symptoms. This is a meta-analysis by Eric Shah, who actually amalgamated data from a number of clinical trials, mostly case control studies, that very clearly shows an increased likelihood, a tenfold increased likelihood of a positive breath test in IBS patients compared to non-IBS patients. Now, at the current time, not unlike diet therapy, as we mentioned a moment ago, we're really practicing an empiric style of medicine. In other words, if a patient has IBS-D symptoms, we think about treating them with rifaximin. But given this potential relationship with small intestinal bacterial overgrowth, is there a way to leverage that might identify patients more likely to respond to rifaximin? And the preliminary evidence from studies so far is yes, that is probably true. There is data from a study looking at small bowel aspiration and from breath testing, both of which show that individuals with evidence of bacterial contamination of the small bowel by quantitative culture or by breath testing are significantly more likely to respond to rifaximin. So it may very well be that as time goes on, we evolve our thinking to employ biomarkers like breath testing, for example, to identify the patients who are most likely to respond to a course of rifaximin. All right, let's finish up by talking about fecal microbial transplant and just mention that there's actually quite a few studies evaluating FMT in patients with IBS. A recent meta-analysis published in Elementary Pharmacology and Therapeutics summarized data from 5 randomized controlled trials. And I think a subgroup analysis from this meta-analysis is very interesting because it suggested that there may be differences in response based upon the way that the FMT is administered. So capsules appear not to work at all in the studies that are currently available. On the other hand, colonoscopy and nasojejunal tubes may provide a better response. Now, it's important to mention that at the current time, when you look at all the data together from those 5 randomized controlled trials, there is no statistically significant benefit offered by FMT compared to sham FMT. But again, there are a lot of details to be worked out that may allow us to identify the right way to administer the fecal microbial transplant and the right patients that might benefit from a fecal microbial transplant. So to summarize, treatments that affect the microbiome improve symptoms in a subset of IBS patients, and this extends to possibly probiotics and prebiotics, although right now the data is pretty shaky for both those. Antibiotics, no question that makes a significantly greater subgroup of individuals with IBS better. Diet, right now, the most evidence-based is the low FODMAP diet. FMT, again, very experimental right now, certainly should not be considered a standard treatment for patients with IBS. The microbiome and metabolome might be leveraged to create biomarkers, which could assist in the diagnosis and treatment selection of IBS patients. So with that, I'm going to conclude and thank you for your attention. I hope you enjoy the rest of the meeting.
This session is open for questions to our faculty. The faculty is now live, up there on the screen. So I'll ask if you have any questions from out in the cyber world, please send them in. If you have any questions from here, please, if there are cards to fill out. But I think we'll start. And I really might as well start with you, since you're in our bottom right corner. Can you hear us? But we can't hear you. So
You're on mute, Ira.
Ira, I think you're on mute. Oh, now I feel much better. Okay. So Ira, the first question really is, it's a two-parter, and it concerns Augmentin, because you had mentioned that.
Yep.
The first one is really, in these patients, how long does it take for Augmentin resolution, hepatotoxicity to resolve? Do you, I know you showed things up there, but do you ever put them on urso or steroids? And have you seen patients after an Augmentin hepatotoxicity go on to develop chronic disease?
Well, the answer to the last question, David, is no. But I think it's important, and I think I mentioned it once, to understand how long this really very debilitating syndrome can go on. I've seen it go on for months, where patients were even jaundiced for months and or had terrible pruritus. Of course, I've seen some resolve more quickly, but when you first see a patient, particularly if they're jaundiced and very, very itchy, although itching has always been present in these patients, you do have to prepare them for the fact that it may be a long ride.
Okay, thank you. So our next question is for Dr. Moshiree.
Oh boy.
There you are, okay.
I hope you can hear me. Can you guys hear us?
Just fine, absolutely.
Oh, good, okay.
You had mentioned the potential use of tricyclics for fecal incontinence. And so one of the questions that's been asked is about side effects. Since many of these patients are going to be elderly, are there any potential concerns about using these medications in the elderly based upon their side effect profile, in particular gait disturbances and others that may affect that population?
And yes, absolutely. So that's very valid. Usually when we use the tricyclics, of course, one of the side effects is constipation. I think they're particularly useful for this rectal hypersensitivity that some of these patients may have. But usually we use them at a very low dose, and we are cautious about the other side effects, even the anticholinergic side effects as well. So usually we use them at 25 milligrams at bedtime, and then we try to increase them if the patient's able to tolerate it after a whole month. So usually I'll wait a whole month, and then I'll increase it to 50. And I'll try, especially in the elderly, not to increase it too much to have the other side effects as well. But that is definitely a potential side effect.
Great, thank you very much. Dr. Chey? I'm sorry?
Yeah.
I got to look at the camera. I'm sorry. I was trying to look at the speakers. So,
No problem.
Dr. Chey, one question here is about the role of breath testing in clinical practice in IBS. When do you use it? How do you use it? Oh, I can see you straight ahead now. That's better. Okay.
Yeah, this is an evolving question. So, it's interesting at University of Michigan, I have fellows that say to me all the time, they'll say, why is it that some attendings order a breath test in every patient that looks like they have IBSD, whereas other attendings never order a breath test? And, up until very recently, I would actually argue that the data wasn't robust enough to really support a recommendation for doing breath testing. But I have to tell you that over the past year and a half to 2 years, my opinion on this has changed quite a bit. And the reason why is because, as I showed in the talk, there are now multiple studies, at least 3 studies. I showed data from 2, but there's another study from China, all of which showing that identification of patients with bacterial contamination of the small bowel or identifies the individuals who are most likely to get better with rifaximin. So breath testing is actually a very good way of enriching the population of patients that get better with breath testing. And here's the thing, remember that empiric rifaximin makes 40% of IBSD patients better. That's better than placebo for sure, but that's not even half. So if we could do a test that allows us to identify or allows us to enrich the likelihood of response to 60 to 80%, maybe we should be doing that.
And is that test readily available around the country, or is it really limited to, more specialty centers that have it?
So this is also a rapidly evolving question, because for many years, breath testing was confined to larger tertiary care centers or large group practices. But nowadays, with the advent of mail order breath testing, anybody can do breath testing. Even the smallest practice in the United States, if you want to do it, can actually do high quality breath testing.
I think that's very helpful. Thank you very much for that.
And to actually add to what Bill was saying, now we have the home test kits, so the patients can actually just pick it up, especially with this pandemic. They can pick them up, perform them, and then turn them in if the center is even interested in doing that. So a lot of labs have turned to that as well. Great.
Thank you. Ira, we'll come back around to you. There's a question here about nivolumab. You talked about autoimmune hepatitis being caused by certain medications. We're beginning to see more and more autoimmune disease with the use of nivolumab for HCC and others. How do you treat that? And if they've developed it once and are under control, would you consider recommending restarting, or once they develop the side effect, we stop?
I think it depends on how severe the side effect was. I don't have personal experience re-challenging patients who've had grade 2 or 3.
So let's say the transaminase is a 300.
What was the first? The bilirubin you said was?
Bilirubin is normal, alkalis is normal. Let's say bilirubin is normal, alkalis is maybe 300-400, and ALT, AST are also in the 300s on nivolumab. Not an uncommon scenario.
Yeah, I think I'd be willing to restart if the patient recovered reasonably promptly. David, if I may add, I didn't finish answering your question before about Augmentin. You asked if I'd ever used prednisone. I did once, and I wasn't impressed. With urso, I just want to point out that you have to remember in very cholestatic patients, urso can actually make pruritus worse, and I tend not to use it for these patients.
Okay. What about steroids for autoimmune disease caused by nivolumab?
Yeah, that's recommended, and in that algorithm that I showed, it was recommended for bilirubins when they start going above 1.5 and ALTs above 3 times normal.
Okay, great. Thank you very much for that. I'm trying to go in order if I can, if that's all right. So Dr. Moshiree, there's a question about fiber. You mentioned fiber as the first line treatment. So what kind and how much fiber do you typically recommend to these patients?
And again, that's a great question. So the trick here is to use fiber that has a combination of both soluble and insoluble fibers, because as we all know, that fiber, can cause a lot of bloating and has an osmotic effect in the gut, and there's bacterial fermentation, so patients can have increased bloating if you start at a very high dose, especially. So usually the studies that have been done with Metamucil and then and brand, comparing like Metamucil to brand. That's what we presented here, and there has been more of a benefit with using Metamucil, which has a combination of both soluble and insoluble. Usually in our practices, we use the lowest dose, which is the 5 grams a week, and then we increase it incrementally weekly up to 30 grams a day if that's what's necessary, if we're really using it to bulk the stool in a patient with fecal incontinence and to actually improve sphincter tone.
Great.
So we don't always go to 30 grams from the get-go because patients will have more bloating.
Great, thanks. Dr. Chey, your thoughts about the gut microbiome and its correlation with NASH, NAFLD. And there's a lot of that now coming in the literature. And we had the first session had NASH and NAFLD in it, but what about that correlation, if you know, gut microbiome and NASH, NAFLD?
Yeah, I think a broader question, I'm going to bounce this in a second to Ira. I'm sure he's got some opinions on this, but I think a broader question really has to do with the relationship between the gut microbiota and metabolic syndrome, because NAFLD is really the hepatic manifestation of metabolic syndrome. And I think increasingly the gut microbiome is being found to play an important role in the development of diabetes, cardiovascular disease, as well as NAFLD. So, in a much broader context and potentially with much broader ramifications in regards to developing biomarkers and or treatment interventions, this relationship between the microbiota, and metabolic syndrome, I think, is going to be an incredibly important line of research going forward. But I would bounce the specific question about NAFLD to Ira. He knows a lot more about this than I do.
Consider it bounced, Ira.
Thank you. I can only affirm what Bill said. This is a huge topic that's emerging in NASH. If you try to read this literature, it's very complicated. People have described alterations in the microbiome in people with NASH compared to normal people. The pathogenetic theories abound, ranging from alcohol production by certain bacterial species to much more prevalently this whole concept of a leaky gut and absorption of toxins from bacteria. I can't give you a thorough exposition on the science right now, but I do believe that we're going to see eventually the emergence of therapeutics, which already are targeted toward multiple things inside the liver or even the intestinal mucosa in terms of different receptors. But I think we're going to see some more gut microbiome specific types of therapies emerge eventually.
Great. Dr. Moshiree, we're back to you, and we're back to tricyclics. So,
Okay.
do you add, or do you have concerns, or do you add tricyclics in patients that are taking other antidepressants? In particular, so many of the patients we see are on SSRIs.
So we can definitely, that's called augmentation therapy. And I think the person that knows probably the most about that is Dr. Grossman. And, you know, we can step up therapies. I think if you're going to do that and you're not a psychiatrist like Dr. Grossman is, it is best to work with a psychiatrist if it's also that you're, you know, trying to help their mood disorder and anxiety and things like that. I normally, if they're already on an SSRI or a SNRI, I'm comfortable with using them at low doses, but you have to be aware of all the side effects and the interactions. So you have to do it very carefully and escalate it up. So it can be done, but I would be cautious and try to work with the clinician who started these drugs in the first place and really communicate with them, especially when other like antipsychotics are being used.
Great. Like, I'm going to ask you two questions since you punted the other one. First one is we're going back to breath tests. And would you prefer lactulose or glucose tolerance, glucose testing?
Yeah, so that is a bit of dealer's choice. So just going through the benefits and problems with each of the tests. So lactulose, because it's a non-absorbed synthetic disaccharide, so nobody can break down or absorb lactulose. So 100% of human small intestines cannot break down or absorb lactulose. So it gets all the way through the human small intestine. It gets to the colon where it's fermented. So bottom line there is if you have bacterial overgrowth anywhere in the small bowel, you're likely to pick that up with lactulose. But if you wait long enough, after you give lactulose, virtually everybody will have an increase in breath hydrogen or methane excretion. So lactulose is probably sensitive, but not specific. Glucose, on the other hand, is avidly absorbed. It's a huge load of glucose. 50, 75 grams of glucose is completely gone by the time you get to the mid-jejunum. So it does not get to the distal small bowel. So here, if you get a rise in breath hydrogen or methane excretion after you give a big slug of glucose, it's probably bacterial overgrowth someplace in the proximal gut. But the problem is if you have distal small bowel bacterial overgrowth, you may miss that with glucose. So glucose is more specific, but perhaps less sensitive. So right now, ironically, we're in the midst of a large study directly comparing glucose and lactulose breath testing to identify patients with bacterial overgrowth and to determine which one is a better predictive response to rifaximin. So by next year, I'll be able to answer this question very specifically from our study.
All right, so we'll make sure the sponsors know that, so you'll come back next year to answer that question. But the second question, which I think is fascinating, is the innate microbiota across the world the same? Yeah. Meaning, the people in the U.S. versus Norway versus Korea have the same microbiota, and if there are differences, could that help explain differences in IBS that are seen?
So the answer to your first question is no, and the answer to your second question is yes. So specifically, there are marked differences in the microbiome and microbiota from population to population. You know, Gary Wu from Penn has done really elegant work showing us that you can alter the relative proportions of bacteria expressed in your microbiome simply by just changing your diet. So if you're taking a really high fiber diet or a really high fat diet, that will favor different elements of your microbiome. So there's tremendous difference based upon diet and genetics. I think I showed a slide in the talk that really talked about the fact that microenvironment actually trumps genetics. Genetics are important, but your environment is the most important determinant of your microbiota. And might that explain, or might that provide an explanation for differences in IBS? Absolutely. Now, the specifics in regard to that are still a bit of a black box. We're doing a lot of research. Obviously, many of us are doing a lot of research in this area right now, and hopefully we'll have more specificity in terms of being able to answer that question. Right now, all we really can say is that the microbiota for patients with IBS clearly differs from healthy individuals, and that there are population-based differences.
Great, thank you so much. Ira, I'll come back to you. Question about risks of DILI from statins in patients with chronic liver disease. Is it a problem? Are there certain patients you wouldn't give statins to?
Right, that is the eternal question. It's been coming up for more than a generation, I'm sure. And of course, people still, although to a lesser degree than before, have the misconception that statins are contraindicated in chronic liver disease. In fact, most of the accumulating evidence suggests that statins are not only not contraindicated, but beneficial even in patients with cirrhosis and even in patients with advanced cirrhosis, where it seems to mitigate the risk, believe it or not, of hepatocellular carcinoma. Nobody's recommending that we do that routinely in decompensated patients solely for that purpose. I think it's safe to say there's really no well-established chemopreventive for HCC, though we desperately need one. But the point is that patients with mild or moderate or even advanced liver disease who need a statin should take a statin. The asymptomatic liver enzyme elevations might confound your ability to interpret what the natural course of their liver enzymes might be. If you're in the middle of trying to assess that, you have to try to take that into consideration, but it still wouldn't contraindicate it.
Okay, thank you. We'll go back to fecal incontinence. Do you recommend biofeedback for abnormal ARM, or do you do other testing like dynamic MRI prior to sending them to biofeedback?
That's a great question. So really, I rely not on the anal rectal manometry alone. I think we do need 2 tests, and that Rome criteria for fecal incontinence actually dictates that to call it a functional defecation disorder, you do have to have 2 tests that are abnormal to call it like a defecatory disorder. So usually, depending on the findings, I will not rely on the anal rectal manometry alone. I'll order that and usually preferably a balloon expulsion testing. And this is particularly talking about dysynergic defecation that requires referral to for biofeedback therapy. And so yes, we definitely think that biofeedback therapy is effective, as we showed. For fecal incontinence, anal rectal manometry is helpful. If there is some evidence of sphincter weakness and there's been a OB history of episiotomy or some kind of sphincter damage from other surgeries, dilations, or hemorrhoidectomy, then we usually do ultrasound as well to see where the exact defect may be. And in most cases, biofeedback therapy for those patients, especially if it's a impaired propulsive force or weak sphincters, can be very effective. Now, the requirements by CMS for biofeedback therapy, which used to be performed by nurses and physical therapists, have changed. So nursing staff can no longer perform these in labs around the country that were doing them. So at least in our practice, we now just send them to physical therapists who really is more versed in the anal rectal physiology and focuses on this area specifically.
Great, thank you very much. Dr. Chey, question about the origin of IBS. Is strict bowel training in childhood versus lax training a factor in developing IBS later on in life?
I'm going to answer that not by answering your question. Okay, so there's no question that early life events predispose to a greater likelihood of developing IBS in adulthood. Okay, so the things that we know for sure are, for example, early life trauma, So physical abuse, sexual abuse, verbal abuse, all increase the likelihood in a susceptible individual of them developing the clinical phenotype of IBS later in life. Altering the microbiome, such as can happen with repeated courses of antibiotics in childhood, can also increase, or definitely does increase, your likelihood of developing IBS later in life. As to the specifics of your question, I don't know of any literature that absolutely draws that association, but early life events are critically important. It's really interesting, actually, if you, in maternal deprivation models, if you simply take mouse pups and separate them from their moms, they're much more likely to go on and develop an IBS-like syndrome. So maternal deprivation is also another predisposing factor in a susceptible individual for developing IBS.
Thank you. Another question coming to you, which is, you've talked about rifaximin and it works, but what about in that subset of patients that can't get it because of insurance, which is a problem? Is there a second choice antibiotic that's as effective or nearly as effective?
Yeah, so my answer is going to be clearly non-evidence-based. So there's one study actually by Uday Ghoshal who did a study in India with norfloxacin and showed that it was effective for a subset of individuals with IBS and SIBO as well. So that argues that quinolones, and that's actually one of my favorite alternative choices, is either Cipro or Norflox. Another drug that you could surmise might be beneficial would be Augmentin. So amoxicillin clavulanate is another popular choice. Other things that people have used for bacterial overgrowth, not IBS, bacterial overgrowth, include tetracycline, Bactrim, Flagyl, so with varying degrees of success. Probably my three favorites are rifaximin, Cipro, and Augmentin.
And how long do you keep them on those?
Yeah, I treat for, according to the FDA guidance for IBS-D, so rifaximin 2 weeks. Cipro I usually treat for around 10 days, but this is just my experience. This is not evidence-based. And similarly for Augmentin, I usually treat 7 to 10 days. And basically, it depends on why you're treating. So how you manage a patient with IBS-D long-term is very different than a patient with scleroderma, where for sure, once they start getting bacterial overgrowth, they're going to keep getting bacterial overgrowth over and over again. So the clinical circumstances, the indication for which you're using the antibiotic also plays into the frequency with which and the threshold that you use to retreat with antibiotics.
Great. And last question, because you're running out of time, goes to Dr. Moshiree. You talked about the defecation angle. And so it's an interesting question. So they've seen a lot of ads. Would you recommend that squatty potty that they talk about? Good question as our last question, right? The squatty potty.
Absolutely. Absolutely. For $25, you definitely get worth what you're worth your money. So I recommend that often. That's a very typical recommendation we make for most of our patients who have constipation, especially if they strain, if they use manual maneuvers, digital disimpaction, or if they put pressure on their belly when they're trying to defecate. So I think it's an easy thing to get on Amazon for $25.
Can I make a quick comment on
that technology?
Can I make a quick comment on that?
Please.
So if you're doing anorectal manometry at your particular medical center, one thing we've been doing at Michigan for quite a while now is we actually do a balloon expulsion test just like you usually do. If it's abnormal, then we actually repeat it with squatty potty. So we have squatty potty in the lab. And actually what we've identified is there are probably 25 to 30% of patients with an abnormal balloon expulsion test who correct with squatty potty. And guess what we tell them when they leave the lab? Go pick up a squatty potty and give that a try as your next step. We're actually doing a study right now, sort of validating that as a recommendation for all labs that are doing anorectal manometry, and we'll be presenting some observational work on this at DDW this year.
Great.
I think that's fantastic because also, not all patients can go for all the biofeedback sessions, so something that easy can help them then I think it'd be so worthwhile.
Yeah.
So I'd like to thank the panel, really, for giving some great answers, and thank everyone. Let's give them a hand. And I'm going to pass it over to my friend, Dr. Rustgi, who's going to give us the highlights. Squatty potty.
Actually, that brings up the issue of whether there's a deal of the day or on Prime Day for Squatty Potty. But, well, I hope everybody learned some valuable information today. I think we had some great talks, and these Q&A discussions have been extremely helpful. We have a reception in this tent for those who are live on site, and otherwise we'll disband at this point and reconvene tomorrow. Breakfast is in this tent tomorrow, and then at 8:20 the sessions will start. So have a good evening, and we'll see you then. Thank you.